Good morning. I am honored to welcome you to our annual Lupus Conference as we gather to shine a spotlight on a complex and often misunderstood condition. First and foremost, I would like to extend a warm welcome to the lupus warriors, invested caregivers, respected advocates, and dedicated healthcare professionals who have traveled here or are joining us online. Your commitment to advancing our understanding and treatment of lupus is both inspiring and invaluable. Lupus, as many of you know, is a chronic autoimmune disease that can affect virtually any part of the body, leading to a wide array of symptoms and posing significant challenges. Among the many impacts of lupus are those on skin, hair, and eyes. For some, just getting a diagnosis is half the battle. For others, that is only the beginning. Often referred to as an invisible condition, lupus can cause severe pain and fatigue that are life-limiting. Addressing this condition requires advanced medical expertise and an unwavering dedication to improving care. There is a critical need for more answers. We need better treatments, more effective treatment strategies, and increased awareness among both the public and clinicians. Our hope is that today's conference will serve as a valuable resource for lupus management and elevate awareness. Today's conference is more than just a collaborative gathering. It reflects our shared mission of accelerating research, enhancing quality of care, and ultimately finding treatments that work for everyone affected by lupus. Throughout the day, you will hear from leading experts who will share groundbreaking research, clinical advancements, and personal stories. The presentations will cover a wide spectrum of topics, each designed to foster a deeper understanding that will yield meaningful insights. In addition to the profound knowledge shared today, please use this conference to connect with us and one another. There is immense strength in community, and by supporting and learning from each other, we build a stronger foundation to tackle the challenges that remain. I encourage you to network with your peers, engage in meaningful discussions, and develop new partnerships that might pave the way for future endeavors. As we prepare to hear from our presenters, let us take a moment to remember and honor those who battle lupus daily and the tireless advocates on their behalf. Your resilience and courage remind us of the human element that motivates our efforts. In closing, I would like to thank each of you for your presence here today. Thank you to the team of staff who put an enormous effort into planning over the past few months. Thank you to our advisory board members for your thoughtful insight along the way. And thank you to our sponsors, the University of Michigan Department of Anesthesiology, AstraZeneca, and Aurinia for making it all possible. It is only through our shared dedication and collaboration that we can hope to conquer lupus. Thank you.
All right. And then it can affect the skin, which is, what faces the world and is one of the most difficult things for patients because it's changing how people look. It can affect joints and kidneys and many other organs as part of this.
It's giving me, it's advancing here, but it's not. I wonder if it took it out of slide mode. Let me do that again. Let's see. Nope. Let me try something else. I'm sorry. Okay, I think you should be.
Okay, good. So what makes lupus so special? I like to special and not, negative connotation words, right? But I think the things that are, really impactful about lupus is it affects women really at the prime of their life, right? Right when they're like getting out of high school, like trying to make a life for themselves, maybe trying to start a family. This is the, I'm sorry, keep going. Oh, the time when lupus tends to affect, and there's like some interesting research that Black women especially tend to get lupus earlier and have it for longer parts of their lives. So they have a longer impact of how lupus can affect them, whereas white women and Hispanic women tend to get it a little bit later, maybe in their 30s or 40s. We also know that lupus can affect children. So there's some families have a lot of lupus that runs in the family. There's some genetic risks that can contribute to development of lupus. And so kids as young as 2 can come down with lupus. And then we know that lupus also, it's not the same every day, right? There's days where patients flare and they feel awful, and there's days where they feel okay, and, can do a little bit more. And, our goal when we're treating lupus is really to keep those flares from coming back. And we think that lupus is really caused by a combination of both genetics, right? So a lot of people have lupus that runs in their family, but it's not just about the genes. It's also about the other things that your body gets exposed to and how those train your immune system to go off track. And so we think about these as environmental influences, and it can be a lot of different triggers. And we'll talk about that in a minute. So, we're still trying to figure out how all of these things interact, and there's still a lot of research to be done to really understand what are the specific things that we need to do to prevent somebody from getting lupus, for example. And so we think about lupus as kind of this spiral where, you're born with a certain amount of genetic predisposition, and then you get exposed to things like infections, like sunlight, like chemical exposures, environmental contaminations, things in our food. Lots of things can probably contribute to how our immune system behaves. And some of us have a more twitchy immune system than others, and that's really driven by the genetic predispositions. And then we think that these triggers, there's 2 different parts to our immune system, and there's one that's more like immediate. We call that the innate immune system. And that makes a lot of inflammation. And then there's another part that's more trained, and that's what we call the adaptive immune system. So these are our T and B cells. You might have heard of those. And so lupus has issues with both going in the wrong direction. So the innate immune system gets too activated, too inflamed, and the adaptive immune system then develops and makes specific things to target our bodies. So we get T cells that will kill our organs, and we also get antibodies, which you guys have probably heard of getting tests done. So we get these autoantibodies that also can attack our organs. And so this cycle can keep going on and on. Every time we get a trigger for this, it can start all over again. And the other thing that's super interesting is that we know that lupus starts way before somebody ever gets sick. So this is data that was taken from military members, because everyone has to give blood as part of going into the military, and they stored this blood. And somebody went and said, okay, now let's look 25 years later, who in this group has gotten lupus? And then they were able to go back to their blood supply 25 years ago and say, could we see anything in their blood at that time that looked like they were having some risk for lupus? And it turns out that even all the way 5 years before any symptoms started, so these vertical lines here on the graph are when they get sick, you can see that there's lots of different antibodies that they can detect in the blood way before people ever get symptoms. So this cycle of lupus is starting, way before anybody ever comes to the doctor, even starts to have fatigue, hair falling out, the things that kind of start when people are starting to get sick. So it's not just about learning how to treat lupus, but it's really about figuring out how to prevent it, right? Wouldn't that be great if nobody ever got it ever again? This in each along this path, I think I need to push my arrow. So we think about, again, those environmental triggers is what's kind of pushing people along this path. So when you have these antibodies and you've never gotten lupus, we think about this benign autoimmunity. And what that means is your body's made things that are against your own body, but it hasn't caused damage. It hasn't made you sick. But yet another trigger can push you into what we call pathogenic autoimmunity, where now your immune system is attacking your organs and making you feel terrible. And then, more triggers, you can actually show up and get diagnosed finally. And we would really love to be able to intervene before all of that happens. Whoops. Okay. The other thing that makes lupus complicated, right, is every single patient is unique. I don't know 2 lupus patients who have behaved exactly like each other in terms of how their disease presents or responds to therapy. And everybody has different lived experiences. You know, they might have really good access to healthcare. It might be really difficult for people to get to their appointments. They might have a smoker in the house. You know, they might live next to some place that has a lot of pollution. So there's lots of things that each patient's experiencing that will change how the lupus acts for them. And we call this patient heterogeneity, how patients present. You've got all sorts of different manifestations and things contributing to lupus. And so this also makes it difficult to find a one perfect formula for how to treat patients, right? So this also complicates, like, how do we get to diagnosis for patients and how do we treat patients? And really it can make lupus kind of hard to figure out. So who here that has lupus, if you're willing to share, was sick and diagnosed within 3 months of getting sick? Anyone? Couple. Good. I'm glad that you were able to get care super fast. Who took longer than a year? Exactly, right? It takes a long time. The average time to diagnosis is sometimes 2-3 years for patients because manifestations kind of creep up. Things are hard to figure out. I want to say this is the first time I've ever tried to use ChatGPT to make a picture. What do you guys think? I was like, I want a purple butterfly with question marks, and that's what it gave me. So, yeah, so sometimes lupus can be really difficult to figure out. And how do we get to that point? How do we become comfortable and figure out that we're going to tell a patient that they have lupus? And it's really because we use a combination of interpretation of clinical tests, which I'm going to go through some of those too, so you kind of know what doctors are looking at. But we also just think about it in the context of the person's lived experience of symptoms and manifestations, right? So there's lots of things. It's not just about what the tests tell us, but it's also about how your body is behaving at that time. This was another attempt at ChatGPT. I said, give me a wolf with a malar rash in flowers with rain. Because it's like the lived experience. I don't know. It made like a rash on the wolf's nose. The wolf. So lupus, it like is the Latin word for wolf, and that's, you know, where the term lupus originally came from. Okay. No two lupus patients are the same. I think that's just a really important thing that we always have to keep in mind as physicians, but also as lupus patients. You're not going to be the same as your friend with lupus, right? So where do we start when we have a patient who's sick and we're worried about lupus? So there's this classification criteria that we use to sort of come up with a diagnosis of lupus. And the way that we start this classification criteria is you have to have a test called a positive ANA. Everybody heard of that word, the ANA test? Yeah. So you have to have a positive ANA in order to be put into the lupus classification criteria. Very, very rarely people can have lupus without an ANA. And usually that's because the test was done in a funky way or something wasn't quite right. But pretty much everybody with lupus has a positive ANA. But just because you have an ANA doesn't mean that you have lupus. So this is one of the confusing things, right? Is there's no like really good test. So what is a positive ANA? So what we do is we have cells that we put on a slide, and we take the liquid part of the blood called the serum, and we put this on the cells. We let it sit there, we wash it off, and then we come back with a detector that can bind to antibodies if they stuck to the slide. And what happens when you have a positive ANA is that patients will have antibodies in their serum that are able to bind to the nuclei, which is the center part of the cell that has all our DNA in it. They can bind to that nuclei and we can then detect it. And so this is what it looks like. So there's different patterns that we can see in patients. So sometimes you'll see on your test that you get a homogeneous pattern or a speckled pattern. But basically what this is telling us is that you have antibodies in your blood that are binding to parts in the nucleus. So if it's a homogeneous, it's probably binding to DNA because DNA is all smeared around in there. And if it's speckled, it's probably binding to some things related to RNA biology. So we learn these patterns and we care about them because certain patterns are associated with certain manifestations of lupus. Yeah, so the ANA is a test that looks for these antibodies. And then we look at the pattern, and then we also look at the titer, and that is basically how much of these antibodies you have. So if you have just a smidge of antibody, probably less exciting in terms of diagnosis than if you have a really large amount of antibody, which is much more likely to be in a lupus patient. And like I said, just because you have a positive ANA, it doesn't mean you have lupus. So it makes it confusing, right? So we get lots of referrals at U of M for patients with positive ANAs. And just by like looking through the records, I can tell they don't have lupus, right? So there's lots of things that, are caveats here. So lots of times doctors send ANA testing for the wrong reason. So we have something predictive probability. You only want to send a test when you have a really high suspicion that you're testing for the thing that test is going to tell you, because there's a lot of false positives with ANAs. So about 13 to 30% of the population, and the older you get, the more likely you are to have a positive ANA. But only 1 in 1,000 if you're Black, or 1 in 5,000 if you're white, have lupus, right? So we've got 13% of people with a positive test, but only 1 out of 1,000 people actually get lupus. So that's not a very good test, right? Because it gives a lot of people a lot of stress because they're positive ANA. But so this is one of the things I do a lot of in clinic, is like filtering through this and trying to figure out if it means anything or not. And ANAs can actually be positive in a lot of different diseases. So you can have a positive ANA just because you have thyroid disease, for example. So a lot of people get Hashimoto's, they have to take thyroid pills as they get older. So ANA positivity can be part of that. Things like multiple sclerosis, you can get positive ANAs. And sometimes if you get an infection, you can get positive ANAs after an infection. And so there's lots of reasons why people can have this test be positive. Whoops. This is trigger happy, sorry. So patients with skin lupus, so this makes it even more confusing, right? So sometimes patients who get lupus of their skin, especially discoid patients where they get like a lot of the scars on their scalp, they actually will never have a positive ANA. So you can still have certain kinds of lupus without having a positive ANA. So that makes it confusing. And again, I think ANAs really should only be checked in patients who have symptoms that are concerning for lupus. So, the most common thing is we see is that people send it for, somebody who's like in their early 50s and they start to have some joint pain, and it's mostly because they have osteoarthritis, but they send the ANA and it comes back positive. So that's, one of the things we see a lot in clinic. So anyway, so that's some caveats about ANA testing. So I just wanted to go through all that so that it's not a perfect test at all. But if you do have a positive test, we can come back to this criteria and see if there's enough stuff there that we feel comfortable labeling somebody as lupus. So, and the other thing that's tricky is patients can collect these criteria over time. So you could start with just arthritis and joint pain and nothing else, and it would be hard for us to say you have lupus, but you come back 6 months later and now you've lost your hair and you've got arthritis. Now we can say you have lupus. So, so sometimes it's hard because we have to wait for people to get enough stuff to put them in this box. So what are the different kinds of lupus that we think about? So, typically we kind of talk about this based on what body part is involved. And the reason that it matters is because our treatments from a medical perspective are different based on what organ is being involved in lupus itself. So my favorite is cutaneous lupus. This is what I do my research on. So I see a lot of cutaneous lupus patients in my clinic. And there are many kinds of skin lupus. So cutaneous means skin. So the butterfly rash, this is the common one, right? Everybody knows about butterfly rashes. Tends to come on this part of the face, can be on the forehead. Sometimes the same kind of rash, which we call acute cutaneous lupus. Acute means like just happens. And this one can kind of come and go, right? It can sometimes be over the whole body too. And then we have patients who get something called subacute cutaneous lupus, which basically means like it lasts a little bit longer. And this can be like a little bit scaly, can be red, it's usually red, and it can go like on the back and the chest and the arm, but sometimes will come up on the neck. This one doesn't cause a scar. So if we treat this, it'll go away and patients won't have a scar. And the one that we all hate is discoid, because this one causes scar. So this is often on the face, on the scalp, causes people to lose their hair, and it causes scarring, and the hair won't grow back if you get that scar there. So this is the one that I really like to just treat as best we can, because the longer we leave it, the more impact the patient's going to have long term. There's other kinds too. There's tumid lupus, which is more swollen and painful. It gets deeper into the tissue. And then there's lupus paniculitis, which can actually cause inflammation in the fat. And then that causes like a scar that's like sunken in, because it causes the fat to be worn away deep inside the tissue. And this one's also very painful. So there's lots of kinds of skin lupus. You might have heard these terms thrown around, but they're all kind of in that skin lupus bucket. And the thing that's unique about skin lupus is that patients can have just skin lupus and never get systemic lupus, where it's involving the whole body. And then there's patients who can get cutaneous lupus who have awful systemic lupus, right? So it's kind of a scary thing, because you don't know if you're going to have it in your whole body or not. The ones that sometimes are seen only by themselves, discoid and tumid, are the two that tend to be cutaneous lupus only. And then if you have these other types of skin lupus, you tend to be more in the systemic category, but there's always exceptions to the rule. But just so you know, like what we're talking about when we kind of throw these words around in clinic, and it's basically just describing like the rash, but we care because the rashes behave differently, and we might want to reach out and treat something differently, depending. So another kind of lupus, has anybody heard of lupus nephritis? Right, so this is kidney inflammation because of the lupus. And this can affect up to about half of our systemic lupus patients. It's the number one cause of serious health issues in lupus patients, right? Because we need our kidneys to survive. So if our kidneys don't work, you're either stuck on dialysis or you need a transplant. The things about kidney lupus, which sometimes makes it very sneaky, is that it doesn't cause pain. So you don't get pain in your kidney just because you have kidney lupus. The symptoms that people get are nondescript. So sometimes your legs can get swollen. You can get bubbles or red color in your urine, which is a sign that there might be some protein or blood in there. And oftentimes the thing I see in my patients is the only clue is that their blood pressure starts to go up. And we don't know why. And I'm like, we should look at your kidneys. So these are the symptoms that people get. And then in the lab tests that we look for increases in a marker called creatinine. So this is a blood test. You guys probably get this frequently if you're getting monitoring labs. And then we also look for protein and blood in the urine. So these are the ways that we can tell that the kidney's not happy. So there are 2 new drugs that were approved for lupus nephritis in the past several years that have helped us improve our remission rates. But it's still only about 50% of people fully respond to our lupus nephritis treatment. So there's tons of trials right now coming down the pipeline looking at new ways to treat lupus nephritis. We've got one that we're going to be launching at U of M very soon that looks really promising. It's an add-on medication to kind of our standard therapy. And I'll talk a little bit more at the end about some of the other therapies coming down the pipeline. But I think this is going to change, and we're not going to be left with where things are today very soon. And so, yeah, we're doing more research and trying to figure out more therapies there. And then the next kind is CNS lupus. So you may have heard of this. This is basically when lupus affects the brain or the spinal cord. And it causes inflammation there, and it causes lots of different things. So it can cause confusion. It can cause people to have personality changes. It can cause loss of consciousness. I actually had a lupus patient that became what we call catatonic, where she was awake, but she just laid there. She didn't talk, she didn't move, she didn't respond to stimuli, she just laid there. We fixed her, but it's scary when you see that, right? So, and it can even sometimes cause paralysis. So if it attacks the spinal cord, it can knock out spinal cord function, and then you lose the function of your arms or legs. So we don't like CNS lupus at all. The way you diagnose it is basically you have to have a suspicion that that's going on, and then we get an MRI of the brain and the spinal cord to look for inflammation, and then sometimes we also have to look at the spinal fluid to see if there's inflammation there. And it can be really hard to know for sure because sometimes the testing is a little bit subtle. So you really have to have I call it spidey sense, right? That something's going on there. And because the only real treatment we have for lupus nephritis still is cyclophosphamide, which is a chemotherapy drug, right? So we want this to go away. We obviously don't want people's brains to be inflamed, and the only treatment we really have that's been shown to be beneficial is still going all the way to the most aggressive chemotherapy that we have for lupus. So CNS lupus can be super tricky, but we've made a lot of patients better with the cyclophosphamide. So we don't love having to give it, but it does work when we do. And then the other kind of lupus that I think is thrown around is just lupus arthritis. There's a term called Jacquard's, which is a special kind of lupus arthritis where patients' fingers kind of bend to the side. But this is really a frustrating manifestation of lupus because a lot of our therapies are not very good at lupus arthritis. Patients get pain and swelling in their joints, hands and feet, most common, also knees, and then elbows. So I have this clinical pearl I teach my fellows. If somebody comes in and tells me their elbows are hurting, I always make sure I test them for lupus because it's a strange, but I think pretty consistent fact that lupus patients get pain in their elbows. And a lot of times I see patients who've been misdiagnosed as rheumatoid arthritis when really it's lupus underlying their disease. So patients often come in with this label of RA and it's actually not what's going on. And this can be kind of refractory. So we can get their kidney to behave or their brain to settle down. But sometimes the joint pain is just persistent. And then, once you get some damage in the joints, then you get pain for other reasons besides inflammation too. And so it can be kind of a vicious cycle for patients to struggle with their joint pain. And then the other thing that makes lupus complicated, right? It's not like you just have one kind of lupus, right? So patients can mix and match. So you can have, what did I circle here? Headaches and joint pain one day. And then 5 months later, you come in and you've got kidney disease and chest pain, right? So the symptoms can mix and match and come and go. And so it's always, and then the other thing is people can have like other things, right? You can get an infection. You can have a headache just because you were stressed out and people were pissing you off at work, right? So we're always just like, is this your lupus or not? So that always makes it hard too, right? Like, how do I know this is my lupus or is this just life? And, I don't need to stress so much about it. So that I think can make things complicated too. And, how we think about treating patients is really based on the symptoms you have. And so, your doctors are always very organ focused because we want to make sure that we are, not letting anything get damaged. And that's usually where we start with our therapies. But, our lupus medications don't fix everything. This was my own, I made this one myself. I couldn't get the ChatGPT to do it. Like, it was like, give me a black box with like question marks and didn't want to do it. So I think this is the other thing that we're still struggling with is like, in our care of lupus patients, like our drugs can turn the inflammation around, but it doesn't necessarily make people feel better or they get a ton of side effects from the drugs, right? So this is still where we have a ton of room to grow. And so I think coming back to this cycle, I just want to talk about some of the ways that we can maybe, stop this cycle that might help some of the other things besides just like throwing, anti-inflammatory drugs at a patient. What else can we think about? And I'm kind of obsessed with environmental triggers. My lab studies UV light reactions and why the sunlight makes people sick. But I also have a grass-fed meat farm, and I believe very strongly that like what we put in our bodies can harm us, right? So we have to be careful about getting exposed to environmental triggers that can be bad for our immune system. And so what are these triggers? So lack of sleep. So did you know that if we go back to that study where they were following those patients in the military, and they looked at all the things that those patients were exposed to, right? So you're in the military, like there's probably a lot of stress going on. You're like in close quarters, you get lots of infections, eating military food. I'm sure it's delicious. But what are the things that actually predicted who would go on to get lupus from those that had those antibodies at the beginning? The only thing that predicted was less than 7 hours of sleep at night. So sleep is important. This is where our body like rejuvenates itself. It's where our brain lets go. And we know that there's a really strong connection between our brain and our immune system. A lot of those wiring actually happens in the gut, believe it or not. There's a lot of crosstalk between our nervous system and our immune system in the gut. So lack of sleep is important. So I really tell my patients, you've got to try to figure out ways to get better sleep. And it's not always easy, right? You hurt, you know, you've got kids, like there's 20,000 things that get in the way of sleeping. But it's really important to try. Stress is another one. Like I said, there's a lot of connections between the brain and the gut. And so, and I have patients who have like terrible lupus flares after, you know, their mom died and they got a divorce in like the same month, right? That type of life stress where you feel like hopeless and alone, that can really affect your immune system. And so it's very important to find ways to help manage stress. We can't always stop bad things from happening to us, right? But we can try to control how we let our body respond. It's not easy for sure. But stress management is something that I like to talk about with my patients too. It's really important. Diet, as I said, like I grow a lot of my own food because I'm, you know, I don't love the chemicals that gets put into the food in the world. I think Dr. Stubbs is going to be here to talk about nutrition. And I think he'll give you guys lots of ideas on ways to sort of like make simple changes in your diet that can hopefully help. Smoking actually. So, and this applies to all sorts of smoking. You know, my patients are always like, can I use marijuana? And I'm just like, just eat it. Don't smoke it. Smoking is bad. So, the reason is the lung is full of blood vessels and you have tons of immune cells in your lung. And the smoke comes in and just like angers everything, right? Like, I mean, it's an irritating thing, right? Like smoking is not like, you know, taking a bath or something. It's like irritating. And the chemicals that are in the smoke actively trigger our immune system. And so there's lots and lots of data that if you smoke, it makes it much harder to get your autoimmune diseases under control, especially if you have skin lupus. It lowers the efficacy of the medications between 2 and 6-fold. So especially if you don't want to take a lot of pills, so I tell my patients, I'm like, they're like, I don't want to take any more medications. I'm like, well, that's fine. If you just quit smoking, we probably wouldn't need to give you more medications for yours, especially for skin lupus. It's really driven to be more active with smoking. And then sunlight, right? So ultraviolet light. So this is a really weird thing about lupus patients, right? Is that the sun makes them sick. Most of the time we put our kids in the sun and tell them to go get vitamin D, or like if you have psoriasis or eczema, we tell people to get more sun exposure because it makes their rashes better. But in lupus, it's the exact opposite. So this is where I do a lot of my research, and we've got some really cool data that we think we can kind of understand like what are the drivers and why lupus skin is so prone to this. It's a completely different talk. We can talk about it another time if you want. And if any of you participate in our research studies, thank you for that. We get a lot of skin biopsies from our lupus patients to help us understand this. But yeah, so it's really important to avoid the sun. And I tell patients that, you know, doesn't matter your skin color, you have to wear sunscreen. And we've actually, I think, figured out why this is. So, you know, darker pigment in the skin is actually quite protective against aging effects and also skin cancer. And the reason is that the melanin, which is the pigment that makes your skin darker, surrounds the nucleus, which is that ball of DNA, and protects the nucleus from getting exposed to that UV light. But what we found is that the abnormalities that are happening in lupus skin are not in the nucleus. They're actually in something called the mitochondria, which are the energy bodies of the cell. And those are outside the nucleus, and the melanin doesn't protect them. So it doesn't matter what your skin color is. The UV light will get to your mitochondria and cause inflammation. So it's really important that everybody wears sunscreen. So you got to find one that you know is tinted and that you like and that you're willing to put on every day. But if you're in my clinic with me, you will like roll your eyes because I talk about it all the time. All right, and then chemical exposure. So things like lead and mercury, if we give them to mice, we can make them get lupus, right? So these types of things are important in educating our immune system. So again, when you think about something like the Flint water crisis and like the impact that can have long-term on people's health, it's really quite awful. And then infections are the other one. So there's some very interesting data about the virus that causes mono and links that it might have to like sort of pumping up the immune system to be more prone to autoimmune disease. Other infections like COVID, we've learned that it can cause, you know, autoimmune stuff in patients long-term. So we've learned a lot about just how these like triggers over and over again can just keep pushing the immune system in the wrong direction. But these are all things that can participate in that spiral. And we really want to try to prevent and act on these things as best we can in order to keep people as healthy as possible. And then at the end, I'd said, I just wanted to talk a little bit about what's coming down the pipeline. So I think there's just some really great things on the horizon. So you guys might have heard about CAR T therapy. So this is this new treatment. It's really involved the way that CAR T therapy is now. It involves patients coming in, giving what we call a plasmapheresis or a leukapheresis to get a bunch of white blood cells out of the body. And then the patient goes into the hospital, gets exposed to some, I would say, moderate dose chemotherapy to lower their white blood cell counts. Meanwhile, that blood that they took out travels to a lab over here, and they change the cells to put in what's called a CAR T vector that then allows those cells to, when we put them back into the patient over here, to go in and actually kill B cells in the patient. And so this whole process takes a couple of weeks. And then once you get the CAR T cells back, you have to stay in the hospital and be observed, because there's risks that it could cause a lot of inflammation as it's killing up all the B cells in the body. Those patients are really immunosuppressed for about 100 days, and then their B cells come back. And what we're seeing is that the lupus is gone. So it's somehow like resetting the immune system in a way that for most of the patients who've gone through this, now we're talking maybe worldwide, maybe 30 or 40 patients at this point, are able to come off of all of their medications, which is exciting, right? So what I think is even cooler is that now we've got some trials coming where instead of this long process where you've got to like give your white blood cells away, and then they take them to another lab and mess with them, and then you go through chemotherapy, and then you have to wait. Now they're having things that are off the shelf. You don't have to make the own CAR Ts with your own drugs. They've been able to use different types of cellular therapies, something called natural killer cells, that actually you can just take and give a patient. So there's none of this like wait time. And with those cells, they're actually stopping this immunodepletion. So you don't have to get chemotherapy to do the treatment. And then I don't know how much you guys are like surveying the literature, but just the last couple of weeks, there's been another type of therapy called a BITE, B-I-T-E. We call them, the TE is T-cell engager. But this is actually a protein that you get through an IV, just like, Benlysta or anifrolumab or, any of those medications. It's very similar. You get it through an IV, and what it does is it goes into the body and it grabs the T cell and it grabs the B cell and it sticks them together, and the T cell kills the B cell. So it basically does the same thing, but it's doing it without having to use an actual cell put into the body, which to me, I think is safer and is easier because you can do it as an outpatient, right? So we're in the process of getting a lot of these trials up and going at University of Michigan, because I'm very, very excited, especially about these T-cell engager therapies and the potential that they can bring to our patients. And there's other sites around that are also bringing these studies. So, I think the right patients for these are ones who are kind of failing our usual treatments right now, that, have had their Cytoxan, have been on CellCept, and just are still struggling with a lot of lupus disease activity. I think that's where we're going to start. But my anticipation is that if you're somebody who's going to need immunosuppression for your lupus, we would love to have this as an option where we could say, we can put you on immunosuppression potentially for 5 years or longer, or maybe we can just put you through a cycle and cure your disease. So we're not there yet. I think right now, we've got good options, but nothing is perfect. But the goal will be to give people, something that they had, like lupus is a disease they had and not that they have, right? Like that, I would love that. I would be able to retire very happy, if that's where rheumatology is in 10 or 15 years from now. So, I think if lupus warriors that are really struggling with their care and would be interested in these types of things, like my coordinator's email is here. We're going to have these trials getting launched within the next 6 months or so. And it's not for everybody. Like I said, a lot of people do fine with their current management and the meds we have. But if there are people who are struggling, please reach out and we can keep people updated on where we are with these trials. So yeah, I think there's some really exciting things on the horizon. Oops, this was extra slides. So yeah, so we can just talk. I can answer questions, whatever you guys have. I don't know how much time I have left. Okay, good. Okay, yeah, so we've got time. If people want to ask questions about stuff or just want a really long bathroom break. Yes, sir.
And let me start off by saying, excuse me, like, if I get a little emotional. But that last thing you talked about, when you said 10 years, and so in your experience, how long will that be before it be affordable?
Right. So it'll take us 10 years to get it through the approval processes, right? So it was 2 years ago, I gave a talk on the trial process and how long it takes, right? So right now, these therapies are in what we call phase 1 and some early phase 2 trials, which means that they're now getting put into groups of about 100 people. And then once we get a phase 2 trial that reads out successfully, my guess is those will start being finished in about 2 years. Then there will be phase 3 trials launched, which are bigger trials, 300 to 400 people in a trial, 200 to 300 people in a trial. And then you need at least 2 successful phase 3 trials for a company to be able to get FDA approval for a drug. That's when insurance is going to cover it, right? Why I like these T-cell engager therapies, these bites, this like protein that sort of is doing the same thing as these CAR Ts, is because it's going to be much cheaper, right? It doesn't require hospital stays. It doesn't require making a product and like putting it back into somebody's body. It's basically just like belimumab or Safnello or whatever else we've got available now. You just show up at the outpatient infusion center, get your infusion, go home, come back, get your next infusion, go home. And then if it works, hopefully we get people off of medication. You don't need anything anymore. So I think from an equity standpoint, that type of therapy is better because it doesn't require a specialized center to give it. You can get it in the UP, or wherever. Like we can get it to centers all over the place. But I think, clinical trials, you don't have to pay to be on. So people could get access to these therapies through those trials, but until it's FDA approved, we won't have insurance coverage. So it'll be 10 years-ish, probably. Yeah. Yes.
So at the beginning of very great presentation, I appreciate it. And at the beginning, you were speaking about Black women in terms of getting lupus earlier and having it longer.
Yeah.
That's my first question. Do we know why that exists? And then the second question is, with this CAR T therapy and the BiTE therapy, are all lupus patients going to be candidates for those?
Right. Yeah, good questions. So where the epidemiology is in terms of like understanding why Black women get lupus earlier, there's probably some genetic risk in there because it runs in families, right? So that's part of it. But I mean, I think systemic racism plays a part here, right? So people who live in places where there's more pollution don't have as much access to healthcare, maybe have more stress in their life. I think there's socioeconomic things that play into it. So there's lots of factors that are playing into that. And we don't have good, like a percentage is this and a percentage is that. We don't have that type of data. But I mean, we know that all of those things impact and matter. So I think that it's probably a multiple factorial thing. In terms of the bites and the CAR Ts, I'm sorry, what was your question?
Oh, just for all patients.
Oh, yes. Yeah. So for the trials, they're going to start with the really refractory patients because those are the ones who have the biggest need right now because nothing is working for them and we don't want them to lose their kidney. We want them to be able to, go to their kids' soccer games and, do the things that life wants them to do. So those are the people that are going to be put into these trials most likely. And then probably for the phase 3 studies long term, they might loosen up a little because it's hard to find those really refractory patients. They're not like, gazillions of them. So they probably will change who they let into the studies as they get more comfortable with the safety of the medication. And then we want to try to see if it's working for just run-of-the-mill lupus nephritis, for example, or, so they'll probably open it up. And then what happens is once it's approved is the doctors start to get a little creative and like, who can I actually give this to? Right. So, personally, my goal would be that it would be for everybody if it were. I mean, if it's curing people, what the heck? Yeah, let's do it. Right. I would love it if my clinic was like, if you come in and we're like, oh, you have lupus, we're going to sign you up for this. I'll see you, once or twice, and then you'll be on your merry way. That would be amazing. I would love that. So long term, I think, that would be, I think, the goal. Especially if things like bites work where they won't be as expensive as like the CAR T, which is about $150,000, like start to finish, right? So if we can get a bite therapy where you need like 3 injections, the insurance has to pay $15,000 and you're done, you're cured, you don't have lupus, and all the savings that come to them because you don't have all the other things with lupus anymore. Like, I think that's a calculus the insurance company would figure out.
Bite therapy is also 10 years out.
Yeah. So that's actually a little behind CAR T. So those are just coming into phase 1 studies right now. The first report of using bites in lupus patients just came out in New England Journal like 2 weeks ago. It's very new, but I've gone to some of the lectures on it, and like I'm really motivated to bring this to U of M, like to get these trials going, because I think it's super exciting.
Earlier you mentioned about being in-house. Sometimes you have a positive name doesn't necessarily mean that you have lupus. For someone who has a positive name, but the titer is relatively small, but you exhibit at least 7 symptoms related to lupus. Is it in your opinion that the ALA should be repeated at another time?
Yeah, it's a good question. And this is the art of medicine, right? Not everything is black and white. So typically we don't recheck the ANA over and over, because if you're positive enough to be positive, then you're positive. And it really, everything then is based on all the other manifestations and whether there's feeling our treatments would change where those manifestations are going. So we don't have good drugs for like fatigue, right? So if that's what we're trying to treat, I might tell you, let's work on your sleep hygiene, like get off your screens at 8 p.m., like maybe have some caffeine in the morning. Like, there's no good drugs for that. But if it was like your joints are swollen and painful, then then therapy would come to follow, because we probably could use a tray. Yeah, it's a good question. Yeah, it's a very nuanced the ANAs, yeah. Well,
I did see a hand raised on Zoom.
oh, great, thanks.
See,
Can I hear me if I walk away? Didn't know where the mic was.
it's in the
Oh,
ceiling, so it should be okay. I'm gonna try. Okay, the individual that had a question, if you could try to speak, I'm asking you to unmute now.
I was just wondering if the patients with oral lesions, are they considered cutaneous, or is that just part of systemic as well?
Yeah, it's a good question. So it can be in both. So, if oral lesions is the only thing they have, then it would probably be in the cutaneous only bucket. But if they've got oral lesions as part of other pieces of lupus, then it would be systemic. So it just depends on the context of what that patient has besides the oral lesion.
All right, thank you.
Yeah, thank you. Good question. Yes.
Okay, just 2 quick questions, and I just have to look at this gentleman. The presentation was amazing. Really, really informative. So we know that the numbers for women having lupus outweigh, of course, men. But there has been this theory, well, I've heard of it, that men tend to have worse symptoms than equals. So I want you to clarify that. And then secondly, I was so interested in the cognitive part about lupus and how, we have a warrior, we're seeing her go through that. So would this new trial help with, could that really alter and change her cognitive?
Yeah, it's a good question. So the first question about the sex bias in lupus. So it's 9 to 1. So nine women to 1 man is the ratio that we see. If it's skin only lupus, it's more like 4-to-1. So it's not quite as site-based if it's just in the skin, but the systemic form definitely. And you know, it is true that men sometimes can have more severe manifestations or be harder to treat. Why that is? Well, there's things on the X chromosome. So do a little bit of biology. So women have 2 X chromosomes and men have an X and Y. So in women, if you have a risk gene for lupus and it's on your X chromosome, what happens in your body is only one of those X chromosomes gets used in every cell, and it's random which one gets picked. So in a woman, if you've got something that's like part of your lupus on the X chromosome, half of those get turned off in your body. And so maybe that, you know, helps keep things under control. And a guy, they only have 1 X chromosome. So that X chromosome is turned on in every single cell in the body. So if they have the same gene as a woman that's a risk factor for lupus, the guy's going to have it everywhere. The woman might only have it 50%. And so that is probably one of the reasons. You know, I have a son and a daughter. Which one listens to personal hygiene, sleep hygiene, and get off the screen better? I don't know. So that plays a role in that. I'm just kidding, but you know, I think, you know, just how people take care of themselves also matters. And so, you know, whether that plays a role or not is probably individualized. But yeah, so I think the sex bias thing is probably related to the X chromosome. And then what was your second question?
The cognitive.
Oh yeah, so the cognitive stuff. So yeah, I mean, brain fog and lupus is really troubling, right? Well, we don't fully understand why. And then you can, so that's like one aspect of cognitive where people just feel like they can't remember things, their brain's just not clicking on all cylinders like they wanted to. And then there's like the extreme where people are really affected, and that's like raging inflammation in the brain. So that piece we can turn off pretty well, steroids, cytoxin. If that doesn't work, I think these types of cellular therapies could be an option, because the patients that are getting put into the trial so far already have these like really bad manifestations of lupus and have had it turned off. So I think, yes, if the person you're speaking about has like the inflammation piece and is not responding to therapy, that can definitely be part of this. If it's more of the brain fog piece, we don't know how that's going to respond to these therapies yet. I mean, there's just so few patients that have gone through them. The hope is, because we're kind of resetting the immune system and getting rid of all the underlying stuff, that some of these pieces would also improve. But I think we just need to study it. We won't know until we get there, right? For some of it. Yeah.
We have one more question in the Zoom, and then we are reaching the end of our time for the Q&A. This will probably be our last question.
Okay.
If your symptoms are controlled under medication and your ANA and DNA test negative, are you considered in remission?
So always complicated, right? So the blood tests are only part of the story. And so you can have your blood look fine, but you could still be having manifestations otherwise. And so it's hard for me to answer that without knowing like everything else that's going on with the patient. So it would have to be kind of an individualized discussion. Yeah, I know that's super frustrating for my patients, right? So I'm like, your blood looks fine, but you feel like shit, like. Oh yeah, so you know, sometimes you just have to get a little creative and maybe try like dual approaches. Like we could tweak a med, but let's also work on self-care, see if we can reduce stress, if those types of things will help too. Yeah, there's no perfect therapy sometimes for those situations, but okay, I'm getting, my time is up. And I apologize, I would love to hang out, but my mother-in-law is turning 81 and she's demanded that all 9 of her daughters-in-laws come home to Cleveland for a party today, so I have to hit the road. But I, so thank you very much. Great questions, everyone. Really, really smart questions. Thank you. Yeah.
Let's give one more round of applause to Dr. Kahlenberg. So now we're going to have a 10-minute break. I encourage you during that break, if you finished eating, if you want to come fill some of the space up here for our presenters. Yeah, there's still food and coffee back there for you if you want. And we will reconvene at 11 o'clock with a presentation on understanding lupus in skin of color. Thank you all. Okay. I hope you all had a good break. Next, we will hear from Maya Aravind, who will be talking about understanding lupus in skin of color. Dr. Aravind is an assistant professor of dermatology from the University of Michigan. Please welcome Dr. Aravind.
Thanks, Riley. And good morning to everyone. Thank you so much for being here, and thank you for inviting me to present on this topic. So, a little bit about me before we get started. I have a little bit of a unusual path to medicine. I actually studied art history when I was in school, in college, and I lived in New York City after college for 4 years, worked in an art gallery, and then got a master's in art history, and then decided that I wanted to be a doctor. So I had to go back to school all over again. And I always maintain that love of, kind of close observation and the visual component of art history. And I think that's definitely what led me to dermatology, because our skin is what we present to everyone every day. And I have the honor to be able to examine patients' skin closely. Patients come to the dermatologist and they're getting fully undressed. So that can be uncomfortable. And so it's honestly a privilege to be able to do that and help people diagnose skin conditions. So as Riley mentioned, I'm a clinical assistant professor at University of Michigan, and I'm also the ambulatory care clinical chief of dermatology. So I also have a little bit of an operational role at Michigan. So today we are talking again about cutaneous lupus. I don't have any conflicts of interest to disclose. So I just briefly want to go through an introduction, talk a little bit more about cutaneous lupus. Dr. Kahlenberg did an amazing job covering a huge topic, including the skin. So we're going to really hone in on what is skin disease in lupus, different risk factors and triggers, treatment and management, impact on quality of life, and then also some myths and misconceptions. So as we've talked about already, lupus is an autoimmune disease. It affects so many organ systems in the body, but the skin is the largest organ in the body, and that is the one that is what people see right off the bat. The skin involvement in lupus can sometimes be the first evidence of the disease in someone who has systemic lupus. But as we talked about previously with Dr. Kahlenberg's talk, a lot of patients with systemic lupus have kidney disease that can ultimately be significant and lead to mortality. Patients who have lupus also can be in chronic pain, can have arthritis. So there are many different manifestations of systemic lupus. Why are we talking about lupus in skin of color? Well, lupus patients disproportionately affect patients with skin of color. It's often presenting at an earlier age in these populations. We also have already kind of reviewed how there's a higher mortality rate and greater severity of disease in patients who are skin of color. And then also we've talked about how the pathogenesis can predispose patients with skin of color to this disease. There's a genetic component that confers that greater risk. Also, the presentation of lupus in the skin looks different in patients with skin of color. We talked about that butterfly rash, and some of those images you saw were previously in patients with light colored skin. So there's this misconception that lupus is just affecting, when it affects the skin, people with lighter colored skin. But as you can say from your own experiences, that's not true. And we know that patients who have more personal pigment can be more difficult to appreciate some of the manifestations of lupus. So some of the classic signs we think of, a red rash. That red rash doesn't always look red in patients with skin of color. And that can be really difficult for doctors and other people to sort of differentiate. Lupus can also be mistaken for other skin conditions like eczema, psoriasis. It can be mistaken for ringworm, like this patient on the upper right. There are these annular or round ring-like lesions that might be mistaken as ringworm, treated with an antifungal, and it's not getting better. Vitiligo is another skin disease that it can be mistaken for, as we see in this picture on the bottom. That patient has discoid lupus, scarring lupus. And in skin of color, scarring of the skin can also manifest as loss of pigment. So that can be mistaken for vitiligo, which is another autoimmune disease where the immune system is attacking the pigment cells, pigment-producing cells in the skin. A delay in diagnosis can lead to severe consequences, as we've already discussed, and delays in diagnosis, particularly with the discoid lupus subtype, can be incredibly disfiguring, permanent scar. So again, reviewing what are the types of cutaneous lupus? There are many types, as Dr. Kahlenberg talked about earlier. We're going to focus on the three main types. So acute cutaneous lupus, that is the type of lupus that occurs with systemic lupus. And the most common symptom is that butterfly rash. This is transient, it's temporary, it comes and it goes. And when it is present, it's a sign that a patient does have active flaring disease. Subacute cutaneous lupus, it typically will be a more extensive rash. It can look several different ways, but the good news about this type is that it doesn't lead to scarring. So there's not that fear of permanent disfigurement. However, patients who have subacute cutaneous lupus can have pigment changes that can still be disfiguring. Those brown spots that are left behind, those are some of the hardest things for patients to manage on a daily basis, having that disfiguring hyperpigmentation, excess pigment left behind from the inflammation that was there before. And again, with chronic cutaneous lupus, the most common type being discoid, patients can develop scarring. So looking more closely at systemic lupus, we discussed already the different criteria. I just want to highlight that 4 of those criteria are skin manifestations. So this is a way that, dermatologists can be helpful in diagnosing systemic lupus. So those skin lesions that we associate with systemic lupus include that malar or butterfly rash, discoid lesions as well. Patients can also develop sores and ulcers, particularly in the mouth. We call that mucositis. And then that sun sensitivity or photosensitivity. It is truly a multi-system autoimmune disease. So here we're looking at acute cutaneous lupus, the malar or butterfly rash. So this rash is triggered by sun exposure and often occurs weeks before systemic symptoms develop. And it, as I mentioned previously, is a sign of active systemic lupus. Something to note about this type is that this rash spares the folds. The folds we call the nasolabial folds. So the folds that are kind of between, the nose and the lips. And that's an important distinction to make because there are other facial rashes that occur that can sometimes be confused for lupus. So for example, another autoimmune disease called dermatomyositis, that can also present with a facial rash, but it does not spare those folds. And the thought is that, because it's a sun-sensitive rash, you're not getting quite as much sun in those folds, and that's possibly why it doesn't affect those areas. Patients who also have acute cutaneous lupus, as we talked about previously, are more likely to develop systemic lupus. Now, looking at these different skin tones, I think it's important to see the difference in the presentation. So the patient who is on your left, that is a Caucasian patient with the butterfly rash, where you can see it's clearly bright red. That is kind of the classic picture that you see when you're looking in textbooks, talking about acute cutaneous lupus. This middle picture is far more subtle, and probably from the way it's kind of projecting, you may not even see any real skin changes there. But this patient has an acute cutaneous lupus rash. There's a subtle kind of violaceous or purple hue. There often is kind of a grayish hue as well to the skin when there's inflammation that would otherwise present as redness in a patient who's fair-skinned. And then on the right, we can see a patient who has actually much more inflammation in her rash. And this is someone who's probably had this flare multiple times over and over. One thing that we can do to kind of tell if there is erythema or redness in skin of color is to actually press on it. If that color sort of disappears, that tells us that that is truly redness, because the blood vessels that are kind of dilated leading to the observation of redness, they're getting clamped down, and so that redness disappears. So that can be quite helpful. This is a patient who has a more generalized form of the acute cutaneous lupus rash. This can be really subtle. Again, you may, have a lupus warrior coming to their physician saying, this is a really sensitive, itchy rash that I'm having. And it's hard to appreciate if you're not comfortable seeing this, if you're not familiar with what this looks like. This also can be transient, temporary, but when there is involvement of the tops of the hands, the dorsal hands, we know that there's more likely to be association with systemic lupus as well. Another interesting thing about lupus when it affects the hands is that it typically spares the joints. It spares the knuckles. So the active rash is kind of in between those joint spaces. And again, that's different than some other types of autoimmune skin diseases that can affect patients, like dermatomyositis. Dermatomyositis will actually lead to a rash on the joints itself. So there are certain things that are particular to cutaneous lupus that can help us diagnose it. This is a patient who has mucositis, or an ulcer, an erosion on the tongue and also the lower mucosal lip. So these types of lesions in oral lupus can affect any part of the mouth. It can affect the gums. It can affect the inside of the cheeks, what we call the buccal mucosa. It can also affect the palate, the soft and the hard palate. And these types of skin lesions, ulcers, and erosions can be painless, but more often than not, they actually lead to a lot of sensitivity. And it makes it difficult for people to eat or drink. They have pain or burning sensation, and that can be really, really debilitating. This type of rash in the mouth can be mistaken for other skin conditions as well. Some of you may have heard of oral lichen planus, or LP. That's another autoimmune disease that can affect the inside of the mouth. And even canker sores. If your doctor is not familiar with this condition, with lupus, knowing that it can affect the mouth, they may think you just have canker sores and say, you'll be better soon. Just wait a couple days. One thing to know is that oral lupus rarely ever occurs without other signs of skin lupus. So that can be helpful, or systemic lupus. we typically treat this particular component of lupus with topical steroids, but it can be difficult to manage. Moving on to the next subtype, subacute cutaneous lupus. This is a rash that can affect primarily sun-exposed areas on the skin. So we think about the chest, the upper back, the backs of the arms. And there are two main types, annular, which are kind of ring-like or round, and then papulosquamous or psoriasiform. Some of you may have heard of psoriasis. That's another chronic skin disease, and this can be mistaken for that. In terms of blood work, the autoantibody that we see associated with subacute cutaneous lupus is the anti-Rho antibody. We know that this type of lupus actually tends to occur more in white patients than Black. The lesions of subacute cutaneous lupus last longer than the acute type of skin lupus, but heals without scarring. So that is something that we still want to diagnose early and treat. But if it goes, for a long period of time without treatment, again, that inflammation in the skin can lead to pigmentation that lasts for a long time. 10 to 15% of these patients go on to develop systemic disease. So this is a patient who has subacute cutaneous lupus affecting his chest, his arms, and it often does spare the face and scalp. And here we see kind of annular plaques. They have raised borders, central clearing, and you can already see that this patient has some, kind of flatter brown areas on the upper chest that are pigment that's been left behind. I kind of call it like the footprint that's been left behind from the rash. These are, I think, nice examples of the two subtypes we talked about. The annular type, where you see that sort of central clearing, and that can look different. That can look a little bit more purple or gray. And then the raised red border. And then the patient on the right has more of that papulosquamous or psoriasiform type of subacute cutaneous lupus. Their skin lesions are scaly. They're thicker. They can be, more challenging to treat. So again, with skin of color, we think about the skin lupus looking a little bit different. Instead of red, we're seeing more purple, gray, brown. And being familiar with that is important to be able to diagnose this condition correctly. Here's another patient with pretty extensive generalized subacute cutaneous lupus. So chronic cutaneous lupus, this is the subtype that we really want to be aggressive about treating because it causes disfigurement. Discoid lupus is the most common type that we'll focus on, but as Dr. Kahlenberg alluded to, there are other types, tumid lupus, which is deeper in the skin and going into the fat layer, lupus paniculitis, which is inflammation of the subcutaneous or fat, and then chilblain lupus, which can affect, kind of the digits, so fingers and toes. Localized discoid lupus is really just kind of above the neck, and that is the most common type. However, patients can develop generalized discoid lupus, and that's basically anything where there's above and below the neck skin lesions. These are the patients who have a higher risk of systemic involvement. Untreated discoid lesions can actually lead to even skin cancer, squamous cell carcinoma. So the scalp is the most common site of involvement in discoid lupus. Over 60% of patients have scalp involvement. And again, these lesions lead to scarring. And when there's scar in the scalp or any area with, hair follicles, that hair cannot grow back. This is extensive scarring in discoid lupus affecting the face. This almost looks like acne scarring. This is the type of facial scarring that the artist Seal has. So it can look like little ice pick scars. And again, this being kind of the area that you see first, it's really, really disfiguring. We see more kind of depigmentation. This could easily be mistaken for vitiligo. And we're seeing also lupus here affecting the ears. And again, a different presentation in someone with light colored skin where you see that red and scale compared to the patient on the left where that scarring is a little bit more subtle. There's more of that violaceous purple or gray hue. So why are we focusing on skin of color? Again, I think a lot of this has to do with the fact that there are not enough providers, medical professionals who are comfortable with skin of color, who've been trained to look at skin of color. The image on the left is something called the Fitzpatrick scale, which was created in 1975 to kind of subtype different skin. And it was based on your propensity to tan versus burn. And this was used originally to estimate the response of skin to UV light. UV light, even though it's a problem in many skin diseases, especially lupus, we do use it to treat other skin diseases. There's a Eurocentric bias of this, though, and insufficient representation of patients with skin of color. The image on the right is actually a work in progress by an artist out of Spain, Angelica Das, and she is photographing various skin tones in the world. And I just want to read a brief quote from the artist. The background for each portrait is tinted with a color tone identical to a sample of 11 by 11 pixels taken from the nose of the subject and matched with the industrial palette Pantone, which in its neutrality calls into question the contradictions and stereotypes related to the race issue. More than just faces and colors in the project, there are almost 4,000 volunteers with portraits made in 20 different countries and 36 different cities around the world. I just thought this was a really beautiful image and kind of highlights how we used to think about skin of color, but really there are so many different shades of skin tone. We've talked about this already. I'm going to kind of try and jump ahead here. Common triggers, UV light, stress, medications, and infection. So skin of color is affected differently, again, and that has to do with the damage that's done by not just UVA, which is the type of UV light that causes aging, premature aging of the skin, or UVB, which leads to, burning of the skin and direct DNA damage. There's also UVA1 and visible light. And those types of light actually injure the skin deeper and lead to dyspigmentation. So this is something that I think is unique to skin of color and something we need to really focus on. So lifestyle changes are things that can be really helpful for lupus of the skin. Photo protection, we talk about broad spectrum, SPF, sunscreen, UPF clothing, wide-brimmed hats, and smoking cessation is also really important. I put this picture of the sunscreen here that's tinted. That's an important thing to recognize because there are iron oxides in tinted sunscreen, which actually provide more protection against those other two types of light that can be particularly damaging to patients with skin of color, the UVA1 and then the visible light. Topical steroids, some of you may be familiar with these. We use these to treat skin lupus, but there are actually no FDA-approved systemic treatments for cutaneous lupus. So we end up using the same medications that your rheumatologist uses to treat systemic lupus. So Plaquenil, and when Plaquenil doesn't help, we have to go to immunosuppressing medications. Significant impact on quality of life. Patients with skin lupus can have severe scarring, pain, sun sensitivity, and these are all really important to be cognizant of as the patient and provider. It can affect people's self-esteem. It can lead to anxiety, depression, and those visible skin changes can lead to severe stigma. So lupus myths and skin of color, we've kind of covered this, right? It used to be thought that that butterfly rash didn't occur in patients who had brown or black skin. We know that's not true. Photo protection isn't needed if you're darker skin because you're not going to get sunburn. We now know that is not true. That sun protection is going to be key, especially if you can do a tinted sunscreen, to helping prevent some of the longer term complications of skin lupus. So I'm going to finish with this slide. This is my good friend Blair. She is a new faculty member at the University of Michigan, and she is starting our Skin of Color clinic in Ypsilanti, which we're hoping will be ready to open in early 2025. But having a provider who understands you and your skin, I think is really important. And we need to be training more dermatologists with skin of color. There's clearly not enough in all of healthcare, but especially in dermatology. And here are my references. Thank you very much. Sorry, I went over time a little bit. Any questions? Yes, in the back. Yeah.
What other like topical medications would you recommend for scarring that is like quite old? You know,
Yeah. Yeah. So with scarring that's older, where you're not experiencing, other symptoms like itching or burning, unfortunately, there's no topical treatment that's going to get that scar to go away. We cannot get rid of scars. That's a sign of kind of end organ disease. We talked about end organ disease in other parts of the body, right? The kidneys with the skin. Once you have scar, unfortunately, that's there to stay. So there are different ways to cosmetically, kind of enhance the skin, and cover up is really something that a lot of patients do well with, just like we treat vitiligo patients with certain types of makeup. Cover mark is one that is used pretty widely, kind of thinking about more like almost like stage makeup, a little bit thicker. But unfortunately, there are no good topical medicines once you have that scar already. So if a scar is fresh and it has more pink in it, there can be laser treatment done to help reduce that redness. Yeah. Yeah, go ahead.
So, one of the issues that I've experienced is I never got the redness in the butterfly redness, but my face would swell.
Yeah.
And I understand that most recently that they're noticing that is.
Yeah.
Is that correct?
Absolutely. Yes. So again, there's no cookie cutter. This looks like the, lupus for everybody. Look at all those skin tones that we looked at in that previous image. It's going to look different in different skin tones. And so, yes, swelling is definitely a symptom. Sometimes patients will just feel that sensation of burning, or like you're having a hot flash. Not ready for that, but it's coming, right? Yes, go ahead.
How do I know which type of skin lupus they could be?
Yeah. Yeah. That's a great question. You're right. Non-scarring hair loss, non-scarring alopecia can occur in lupus. We typically see it with that systemic type, the acute cutaneous lupus. So that's absolutely right. And I'm glad that, it grows back. Yeah. If you have lupus, it doesn't mean, and affecting your scalp, it doesn't necessarily mean you're going to have scarring. I think our time is up. I'm so sorry, but I'll be here and happy to answer questions on the break. Thank you all so much.
Let's give one more round of applause for Dr. Aravind. Great. So next up, we were gonna have Dr. Aaron Stubbs, who is an assistant professor of internal medicine, speak to us about nutrition for lupus. Unfortunately, we learned last minute that Dr. Stubbs will not be able to join us, so I would like to present you all with two options. The first one is to watch a couple videos that Dr. Stubbs has where he discusses nutrition and chronic pain, not lupus specifically, but does talk about nutrition. Alternatively, we can also hear a presentation from Rachel Bergmans on gaps in lupus research and inequities. So for those on Zoom, if you want to put in the chat either video or presentation for your vote, and then I'll take a show of hands here. Who's more interested in the videos from Dr. Stubbs? Who? Okay, I see one. I see a couple.
Send it to us.
Yeah, we can also send them after.
Send it out.
Who would like to see a presentation from Rachel Bergmans? Okay, great. Give me just a moment to pull up the presentation, but Rachel will be coming up. Okay, let's give it up for Dr. Rachel Bergmans.
Everyone. All right, so I'm going to give a talk a bit about some of the work we've done around understanding inequities in lupus and informing approaches and how we can advance equity in care. So for those of you who aren't familiar, health equity means ensuring that all people have the opportunity to achieve optimal health. It's not a destination or a box that can be checked. It's something that we have to commit to continuously, as we would to any other rigorous standards in clinical care or research. So starting with lupus and health equity, this isn't an audience that I need to tell. Do I need to speak up? Thanks, Toya. Okay, sorry about that. You all know lupus has profound impacts on quality of life in a number of ways, both socially, health-wise, and in your relationships. By and large, there are more profound impacts of these outcomes in Black communities and other communities of color than in white communities. This includes unemployment, this includes kidney failure, and some of those more costly consequences of this illness. Lupus itself is 3 to 4 times more common among Black people, and mortality rates are also disproportionately high. I use this figure because not only does it show, so the solid line shows mortality rates in Black people following their diagnosis with lupus relative to those who are white in the dotted line. So not only does it show that those rates are higher, but it shows that those rates spike up immediately. So if you see within that first year of diagnosis, it's considerably high of a jump and not something you want to see. So what could be going on there? I don't think we fully know, but some things could be delays in diagnosis, quality of care, the amount of stress that people experience, which we know affects these symptoms that people have. Oh, sure. Okay. So before we understand racial inequities in lupus, we first need to know, what are we talking about when we say race? Race is a social construct. It divides people based on things like skin tone. And for some, racial ethnic identity provides an important source of shared history and social connection. But in American society and elsewhere, race also reflects a social hierarchy. It determines exposure to poverty and stress and environmental injustice. Assumptions that there are these biological differences in race are extremely harmful. They've been used to justify slavery and genocide. They can also lead to the underdiagnosis of certain conditions. So for a long time, cystic fibrosis was considered a quote unquote white disease, which means to misdiagnosis or underdiagnosis in other communities. The truth is, it's more the social aspects of race that matter rather than the biological ones. Race does not reflect, it's like a poor proxy for genetic ancestry and geographic ancestry. And it's more so epigenetics that could potentially be playing a role. But again, that's more the social stressors as the cause. So for example, the things you eat, the stress you're exposed to, it affects how your genes are expressed. It doesn't change your DNA, but it changes how they function. And so, for example, in communities where there's more stress, it does affect how their bodies function. But again, it goes back to the social stress that they're exposed to and their environment, not their underlying biology. So, for example, there's environmental exposures that have been linked to the risk of lupus. Dr. Kahlenberg talked about lead and mercury. And we know that because of historical racist policies, Jim Crow laws, historical redlining, Black communities are disproportionately exposed to these environmental contaminants. Moreover, policymakers continue to fail to adequately regulate and resolve these environmental injustices. The Flint water crisis, Benton Harbor are two local examples of this. There's also bias and discrimination in healthcare. Some of the most seminal work on the fact that there are these racial inequities in healthcare are around pain. And so pain tends to be underestimated in people of color. There's false beliefs within some medical trainees who have reported that they assume that Black people have thicker skin than other skin tones, and it's just not true. But we also know that those assumptions influence the quality of care that people receive, the type of treatments that they're recommended. Additionally, race is intentionally factored into clinical decision-making. It's not just implicit subconscious bias. So there are algorithms that the medical fields will use to determine who's eligible for an organ transplant, including kidneys, which we know affects people with lupus. And that can mean that Black people are less likely to be considered, quote unquote, eligible for a kidney donation, which again can have consequences for their health outcomes. And certainly there's a justified lack of trust within communities. So Henrietta Lacks, the Tuskegee syphilis trial are two examples of this. And when people say, you know, these things are in the past. For one, Henrietta Lacks, her ancestors did not reach an agreement with the NIH until 2013 about the use of their genetic data. And so the fact that that is so recent, I think really speaks to an issue that is still a problem. And then certainly that last slide, the fact that we are still considering race as this decision maker and who gets access to quality of care. And underrepresentation in lupus research is also a concern. So it's estimated that about 43% of people with lupus are Black, but they only represent around 14% of those in clinical trials. I think that comes down to certainly the justified distrust. Also, where are these studies being held? They tend to be held at academic centers. And when you think about who has access to those things, there's big disparities there as well. I also want to say that there's underrepresentation in the decision-making around research, around the people doing these studies, and that affects the quality of them and their relevance to communities. And so to summarize, this is a conceptual framework for health inequities. You can see how past and present policies intersect with social norms and values, which lead to the unfair and unjust distribution of opportunity, which in turn affects social risk factors. So environmental exposures, exposures that are associated with psychological stress, like food insecurity, poor access to transportation. And these things we know affect health and well-being through several different mechanisms. So physiologic stress, psychological stress, and then there's also behavioral risk factors. So I know Dr. Aaron Stubbs was going to be speaking on diet and nutrition and how that is important to health. But when you think about a doctor telling a patient you should eat healthy, I think you can't say that without having a better understanding of what types of foods do they have access to in their communities. Likewise with medication, medication adherence is sometimes something that physicians will emphasize in a visit, but is a person able to afford the medication? That question came up earlier. I think there is a lot of concern about, as we advance treatments, are they going to be accessible to everyone? So now that we have a basic understanding of racial inequities in lupus, you might see why there's a better need to understand these gaps and figure out how we can do better. And so I'm going to present a little bit of one of our past studies. We used qualitative research to interview Black people with lupus to get their perspective and their experiences on where can we do better and address these gaps in care. Qualitative research has several advantages. You know, for one, we're not asking for biological samples and trying to do these really invasive procedures in order to answer these questions, but it's also very helpful for answering how and why questions that underlie associations that we may see at the population level. So for example, some of my past work has looked at how food insecurity is associated with depression, but why is that? And it really is this qualitative work that can help shed light on that. And so again, we use that spotlight approach. Our goal here wasn't to determine differences in care. We know the differences are there. That's really the background. What we wanted to do with this study was identify what can be done better. And so participants for this study had to self-identify as Black or African American, have lupus, and live in Michigan. Before conducting the study, we did present the interview guide to a panel of people who had lived experience with lupus to get their input on the questions we were asking. Participants received $25 for participating. And I won't go into the details of the data analysis, but I do want to emphasize that one of the huge strengths of this study and that really made a difference in this work was the ability to partner with our advisory board and have input from people who have better experience and context around interpreting our findings. In terms of who participated in the study, there were 30 participants, and that may sound small relative to some of the trials you hear about, but with qualitative research, this is actually like on par with a very rigorous approach. People ranged in age from 18 to 65 years. 97% were female, which was expected given how much more common lupus is among women than men. I do want to highlight that 30% reported food insecurity. At the time, the national rate of food insecurity was 11.5%. And so these findings are published. They're published in JAMA Open. I'd be happy to share a copy of the manuscript that these results come from, but they really do focus on addressing gaps in care. One of the quotes I'll highlight later, you know, focusing on like, check your bias at the door, seriously. Okay. So theme 1 focused on the awareness of lupus signs and symptoms before diagnosis. Multiple participants experienced years-long delays between their initial symptoms and receiving a diagnosis. This kind of gets back at that earlier figure of why is lupus so severe in Black communities relative to others. Second, sometimes a diagnosis was the result of hospitalization or multiple hospitalization. And third, this is a big one. People are not always aware of their family history related to lupus. You know, we know the cause of lupus is complex. There is some inherited element likely playing a role. But I think this is a big one because if clinicians are trying to get a sense of if you have a family history of lupus to make a diagnostic decision or a referral decision, that may not be a great fit. It wasn't until after people learned of their own diagnosis that others reached out to them and kind of disclosed that information as well. And so a quote from this theme said, "I remember telling my best friend, this is one of the worst things I'm ever going to say, and I feel guilty about it, but I wish I had cancer. I wish it was something definitive like that because cancer would be easier than not knowing." And I just think this person is really emphasizing how hard it is to be just in that state of confusion, to know there's something wrong internally, but not having answers for a year or more than a year. The second theme, clinician-patient interactions. In this theme, participants talked about how lupus care was affected by how they were treated by clinicians. Some participants experienced racism or had symptoms dismissed by their doctors. Care was better when doctors worked with them toward treatment goals. And when, you know, with lupus, there's many providers who need to work together to have adequate care for individuals. And so when they worked effectively together, that's really what made the difference. And so a quote from this theme, "It was really hard for my symptoms to be taken seriously, for physicians to take a deep dive into and not exhibit any bias or assuming that I'm looking for opiates and other pain management. Don't get me wrong, I had a lot of pain, but I really wanted to get down to the cause and not just manage the symptoms. The physicians probably could have checked their bias at the door and not just about my race, but about my gender and about my symptoms in general. They could have listened to me. And that's another thing we see with lupus. So it's not just race that can be stigmatizing in the context of medical care. Certainly gender, women and pain care is another issue that needs to be addressed. But then pain care in general, there's just a lot of barriers around people getting access to the treatments that may be most effective for them. The third theme being medication adherence and health effects. So lupus medications can be cost prohibitive and have severe side effects. For some people, talking about medication adherence and symptoms with healthcare providers helped with tailoring their treatment plan. A quote from this theme: "If my symptoms aren't really, really bad, I'll skip a dose or two, which my doctor doesn't like, but I have trouble just thinking, damn, I'm taking all this medication or all this medicine. Like, what is it doing? Is it going to help in the long run, or is it going to hurt me more in the long run?" And yeah, lupus is a unique condition where some of those medications that, if they are taken long term, they have very severe side effects. Theme 4 being comprehensive care plans after diagnosis. So in this study, people talked about wanting care to focus on their overall health and well-being, not just a single blood test, not just inflammation. People want more support and resources for non-drug therapies, and social risk factors can affect lupus management. A quote from this theme: "I wish there was something that I could do besides taking narcotic pain medicine for the pain. I wish it was something else that I could do." And, we give a variety of talks through our center on chronic pain and some of the comprehensive strategies that can be helpful for it. So if you're interested in that, please follow up with us. So in terms of the policy health or public health and policy implications from this work, for one, we identified opportunities to improve lupus care, such as preventing exposure to racism, discrimination, and bias, ensuring that people receive additional treatment for symptoms beyond just their inflammation. So the fatigue, the pain, mental health concerns. Reducing the time for diagnosis could alleviate some of these health inequities, and increasing awareness of lupus and diagnostic criteria could be one way to reduce these delays. Participants did speak positively about when a provider would work with them as a team, monitoring their medication adherence as their symptoms change, so that they could kind of figure out what is the best level of medication for their individual case. We hear time and time again how lupus really does vary from one person to person. And so figuring that plan out is an important part of very higher quality care. This work isn't without its limitations. Black communities are not homogenous, they're extremely diverse. And so we shouldn't assume that these findings just apply to everyone. At the same time, we didn't consider the intersection of race with other social factors. Race is one type of social identity, sexual orientation, gender identity, social class are other factors that could be playing a role. And certainly, I think there may be some similarities when looking at these results to other conditions or other marginalized groups, but I wouldn't encourage kind of applying these findings to other groups without getting specific data. In terms of further reading, we have other work published around how to increase engagement and inclusion in research. There's actually a paper, I haven't had the chance to share all this news yet. A third paper we've been waiting to get published as well is around how lupus intersects with occupation environments and social settings that was recently accepted. So that'll be coming down the road. And we have other studies that are ongoing, thinking about what are some of those comprehensive treatment approaches that could be effective around nutrition and physical activity that we're excited to share with you all, hopefully in the months and years to come. And, we're not done there. We're really interested in translating these findings beyond just the research. Research is great. It takes a long time, though. It's not always successful, and community needs are more immediate. So we're really trying to do better in this research model, really sharing results, having that accountability to feed back what we're learning to communities that can benefit from it. It includes some of our other programming, which includes some mindfulness courses, a yoga therapy series, and FAQs. And certainly the conference like this, we really hope to have a broader impact as well. There is also the Conquer Lupus website that's out there that talks more about lupus and chronic pain and some of the resources that could be beneficial to managing some of those broader symptoms that remain unresolved despite someone being treated. Thank you. That's all I have. Any questions before we break to lunch for lunch? Great. I'll leave it at that. Thank you.
Okay, everyone. Thank you all for your flexibility in waiting a little bit longer for lunch than we had anticipated. We're going to go ahead and proceed with our next presentation that was originally planned for after lunch. We're going to be hearing from Keith Binion from the Michigan Board of Pharmacy about pharmacy and lupus, medications, and contraindications. Please welcome Keith Binion.
All right, how's everyone doing today? Good, good. I figure I put on my purple to kind of be in the lupus thing. Is that all right? Okay. Good. The key is always the socks. The key is the sock. Okay. All right. So thank you for inviting me. I'm always humbled to be able to go and present and go and represent my profession. Just background. My background is pharmacy. I love drugs in a good way. In a good way. I've been in pharmacy for a long time and worked in different areas and represent sit on different boards. Just pushing the profession for pharmacy and for pharmacy technicians. And I think one of the most humbling things a couple of years ago when I got a call from our governor, Big Gretch, Governor Gretchen Whitmer, to be appointed to the Michigan Board of Pharmacy. And it's for some of the, thank you. So, just to be, to be on that role and just to sit in other areas, just to really push for advocacy. And, so a lot of what we do, like on the Board of Pharmacy and also one of the other areas I sit on with the Michigan Pharmacists Association on the executive committee, one of the questions that the gentleman brought up about certain medications that come out, one of the challenges that you push for is getting certain medications approved and covered, because there could be a drug out there, but if it's not covered, or if it's like the pharmacy benefit managers and different things don't want to pay for it. So that's one of the things that we push for on that other end. It's just for advocacy and prescription reform. So it's a lot of different things. So shifting out of education and now moving into the role of advocacy, just really pushing for the safety of the public. So like on the Board of Pharmacy, that's the main thing we look at, serving the public and making sure that they're safe and making sure that we service people. So I guess hit the thing and I'll advance it. Space bar maybe. Let's try it. Okay. All right. So I don't have any disclosures or anything and stuff, everything. I'm not getting paid a bunch of money to be here and stuff. I like to run my mouth. So how long I got? 2 hours? I'm just 20 minutes. Okay, that's fine. So 40. This one right here.
Yeah, or you can do that.
I can do the arrow or the space. There we go. All right. Okay, so we're not going to really be talking about a lot of different medical advice or different things, but I know that lupus presents itself so many different ways, and you could be sitting next to someone that has lupus and your symptoms can be totally different than the person that's sitting next to you. Medications that you could be taking could be totally different because of your disease state, your family history, other different things that you have going on. So one doctor may go ahead and decide to treat you one way, or another physician may go ahead and try and treat you another type of way with a whole different type of regimen. And what medication may work for one person may work totally different for somebody else, and just of the different factors. I mean, one of the things that you always hear talk about, renal impairment. Okay, so the people that have kidney problems is one of the things they always have to watch for, because certain class of medicines that you could probably go with to treat, you can't administer, because those certain meds like NSAIDs don't filter through the kidneys like they're supposed to. So like, it's one of the problems that, you know, people run into that are dialysis patients. You know, they, you know, normally you get a headache, they say go take a Motrin or Advil or Aleve. They can't take it, so then you have to go with something else. So that's one of the different challenges that you work with. Also, what combination of medications or regimen can you give that will work? Okay, so we talked about who get lupus, and one of the things that we talked about earlier, lupus can affect anybody from little children to older people, and also different races. One of the things that we talked about and learned in our discussion, I really learned a lot just listening to other people, is it can affect different people. You know, one of the things that we talked about earlier was when we talk about the different biases, okay, and how certain diseases or disorders are primarily for like different races of people. One of the myths that they said sometimes with African Americans, you know, they get sickle cell, and, you know, white people get leukemia. Okay. That was growing up. That was something that was kind of like, you know, told to me, you know, might not necessarily be true. One of the things like we talked about, like you saw on the slide earlier, with cystic fibrosis being kind of like a white person disease, but it can affect everybody. So we look at the broad spectrum, lupus can affect everyone. And the main thing is why we look at how are people treated, whether they're men, whether they're women, boys, girls, or whatever. So we're not going to really be giving like medical advice or counseling and different things and stuff, because technically that's not in my scope of practice, and I don't want anybody to report me and I lose my license. So, so we come up with a different way of some of the different things. So as we go through this, and we can make this more of like a, when you see certain medicines that are up there, so I take that, or you would say, oh, I don't take that. And, you know, some of the different reasons why your physician may or may not prescribe that particular medicine is because of the different things that are happening going on. So it's just like a quick summary, some of the different classes of medicines, some of the things that you may go with. From the dermatology standpoint, there are some different medicines that are prescribed that are gonna work locally, and then there are other different medicines that are prescribed that will work systemically. Only thing about it, when you give something that works systemically, it's going to work over the whole body. So if you got your kidney and your liver, different things going on, those are things that the doctors have to take into account. So it's the court. You got a short.
Just better not breathe. Don't touch it, it'll be fine.
Okay. Yeah. Okay. All right. So, all right. So when we look at different medications and what are treated, like I said, drugs are good. You know, drugs are good in a good way. Okay. They speed up or slow down or stop some process that's going on in the body. And when we put drugs in combination, we get different effects. We can get additive effect. We can get an antagonistic effect. You know, additive effect means it's going to do something. An antagonistic effect means that one drug will cancel out the effect of another drug. A potentiated effect, meaning 1 + 1 is 2. So I have this drug and I put it in a combination with another drug. They're going to do a particular thing. Or you can get a synergistic effect. I put two drugs together. That means like 1 + 1 = 5. You know, so if I take this drug and put it with another drug, then it's going to get an added effect. So that's why sometimes they say you don't take certain drugs together. Okay. For example, like if you're taking a pain pill, and alcohol is going to slow down the central nervous system, whatever, and then the drug's going to stay in the body for a long period of time. It's not going to get filtered out like it's supposed to or metabolized. So then the effects of the drug can be a little bit longer and can be harmful what it's supposed to do. Okay. One of the things you have to watch out also we tend to go ahead and listen to Google. Google is our friend. Sometimes Google can be our enemy. And a lot of times just taking different herbals over the counter, supplements over the counter, because when you look at certain things, over-the-counter medicines aren't really regulated by the DEA, so you can come up with your own line of vitamins and, call them KBZ's vitamins or something like that, and they're really not regulated. You may see things in there like bee pollen or different things like that that can really contraindicate, and you have to watch certain things. It's like if anybody know anybody has like epilepsy or has seizure, take scissors. Okay, so you have to watch like taking over-counter medicines like the one that's for memory. I take it, it works real well. It's called I'm just joking, but ginkgo biloba, ginkgo biloba is one that they take, and so it kind of interacts with different things like that, and it can stop the effect of the medicine and not work. So when you're looking at different disease states, those are different things that you have to work for. When somebody say, well, I saw a study, if you take this and it's helped me and it's helped me, what may help somebody else may not help you. Okay. So those are the things that you have to watch for. So one of the first classes. So one class of medicine that's given for lupus are your NSAIDs and your salicylates. So NSAIDs are your non-steroidal anti-inflammatory drugs, okay? And so what they do, those drugs are designed to take care of pain, fever, and inflammation, okay? Another class of medicine are your COX-2 inhibitors, okay? Now you have two COX-2 types of cyclooxygenase. You have cyclooxygenase 1 and cyclooxygenase 2. One is in the stomach, and then one is used for pain, okay? You have a particular type of chemical enzyme. When it gets stimulated, it produces inflammation. So the goal is to go ahead and to block it or to stop it from moving and working, and then you won't get the inflammation. So like one of the things, like when people you hear about like tenderness elbow or swelling in the knees or different things like that in the bursa sacs, you have those different chemicals that will stimulate that, and that's what gives you the pain and swelling. These are more of the first line treatment for pain and inflammation. They're used for like your arthritis, musculoskeletal complaints, fever, and serositis. Your salicylates are they go ahead and treat the antiphospholipid antibodies, and those drugs that fall in that category, your salicylates would just primarily just be like your aspirin. Okay, so some like the non-steroidal and anti-inflammatory drugs, these may be something that you may have taken before. Okay, like Motrin, Advil, you can buy over the counter. Okay, those are essentially the same thing. They just made by different companies. Those are the brand names of like ibuprofen. Anaprox is naproxen, which is prescription. Aleve is a reduced dose of the naproxen that you can get over the counter. Voltaren can be by prescription. And what they've done, if now you see the Voltaren gel, that they use over the counter, that they use works for arthritis. You have to watch sometimes, like I said, if you have renal impairment, you have to work, because even though you may use it locally, anything that goes in the body can still go through, because the skin is an organ and it will go through and it can go. So your doctor may recommend that you may or may not. Rootis is like one of the first generation NSAID. Indocin is another first generation NSAID you have to watch, because they may or may not prescribe that because some of the different side effects. Relafin, Mobic, Clinaril, and NSAIDs. Your salicylates, pretty much your bare aspirin, been around forever. Okay, or like your St. Joseph's little chewable orange aspirins, taste real good. You're not supposed to eat a whole lot of them and stuff, Going back to our childhood. And your COX-2 inhibitors, Celebrex is the only one that's out there now. So Pfizer kind of has a monopoly on that particular drug and stuff. They had the other two that were out there. Voltaren, not Voltaren, but they had another one that they pulled. And then they had another one out there, Vioxx, and they pulled Vioxx because of the black box warning because it was causing ulcers in the stomach. And probably a lot of GI problems. So that's one of the things that they tell you when you take NSAIDs, you're supposed to take them with food. Okay. And then there's a maximum dose of what you're supposed to take. So that way you don't, overdose or overdo it. One of the things you always have to watch for when we do things over the counter, our mentality is always be if I take one, then if I want to get gooder quicker, good is not a word, like I tell my students, but if I want to get better faster, then the goal is to what? Double up. Okay. And so that's why sometimes drug companies are very hesitant when they put certain medications over the counter because of just watching, because it's real easy. Sometimes if people are paying, I'll take one or it's still not working. I'll take another one. I'll take another one. I'll take another one. And the body is not able to go ahead and metabolize the drug out the system fast enough. And then it can start causing other different type of problems and complications. Okay. All right. One of the things like I talked about with NSAIDs and contraindications in people that have lupus, one of the things they're always watching and doing lab work at levels, they're watching your decrease in the renal function. It can increase different type of cardiac episodes with the heart, whatever, GI bleeding, stomachs and ulcers, and aseptic meningitis. Okay. Sorry.
You're not doing
Okay. All right. There we go. All right. All right. All right. Other classes of medicines are corticosteroids, glucocorticoids, and mineral corticoids. Okay. So in the presentation earlier, we talked about for the skin, sometimes they may give different type of topical medications to go ahead and to treat the different inflammation to go ahead and bring down the swelling. They can be given as monotherapy as one particular treatment or adjunct to other different type of treatments. So they may put them in combination. They may sometimes give you an oral and a topical to go ahead and to treat the problem. They control the flares. One of the things we hear about with the lupus and stuff, who has the flares? Okay. I was just asked a question, who kind of has flare-ups? Okay. Different type of flares. And basically it's designed to go ahead and suppress the activity. They work rapidly, okay, because it's going right to the spot. One of the things that happens if I take something orally, what happens? I got to swallow it. It's got to go to the tummy. It's got to get broken down by acid and stuff, pepsin, before it gets where it needs to go. So the dose of the medicine that you necessarily need to take, you don't get the full dose of what you need because acid has broken it down. So that's why sometimes you have to take more oral medicine to go ahead and to get that particular dose of what you're looking for, okay, of where it is to get a level so that you start seeing activity, as opposed to taking something topically. It's going to go right there and work, okay? Like sometimes when people have a bee sting or something like that and they're itching, they may take a Benadryl and may make them drowsy or something and relieve it. But sometimes if you put like some anti-itch cream or something, they may go ahead and take the pain or the irritation right away because it goes right to the spot. And like I said, it can be given topically or systemically, okay? And some of your systemic corticosteroids, one of the most common, okay, prednisone. Does that sound familiar? Okay. Do we like prednisone? Why? That weight, that prednisone is weight gain. Nobody likes the prednisone steroid. It's a weight gain. And then also when you take the prednisone, can you abruptly stop taking it? Yep, you have to go ahead and titrate have to titrate down and titrate off and stuff. And one of the unfortunate things sometimes is when you're on the steroids and stuff, sometimes you may never come off. They may put you down to a low dose of like 10 to 5 milligrams, and you may still be on it for a long time. So those handles, like I call them, may be with you for a little bit longer than what you want. But your prednisone, betamethasone, dexamethasone, your triamcinolone, your prednisolone, methylprednisolone, cortisone and hydrocortisones are your systemic. And then your topicals, clobedazoles, your fluocinolones, mometazones, fluticasone, eclometazones, desonide, and carbates are your topical creams or ointments or gels or lotions that are given and prescribed. So depending on how they want to treat, like I said, from a dermatological standpoint and stuff, I'm sure there's some of these that give, some are stronger than others. Some may only be applied like once a day. Some are like twice a day or 3 times a day, and some of them are as needed. You put them in combination. Sometimes they may give it together. They may give you like an oral prednisone tablet and a topical, and then working together. Sometimes you can go ahead and get a greater effect or a greater outcome of what it is that you're trying to treat. Okay. One of the things that you always have to watch for with your type of steroids, hypertension, ocular changes. Okay. One of the things is lupus presents this way so much different. And when we deal with different type of autoimmune disorders, you have to watch because the ocular changes might not necessarily be the autoimmune disorder itself, but it could be something from the medication that you're taking. So you have to frequently sometimes have to go to the doctor, go to the eye specialist to watch and to make sure. Osteoporosis is something also, because what it does is it can mess with bone absorption and vitamin D. So, one of the things about medications, when you're taking a bunch of meds, working pharmacy and working retail, because I'm not on the counter anymore, but I work different where I work retail, I work hospital, I work children's, I work specialty, I worked psychiatric hospital. And sometimes you get a patient and say, I'm on 10 different medications. They may only have 3 or 4 actual medications that they are really taking to treat, but because of the side effects of the other medicines, they have to go ahead and take something else to counter that. So like if you're taking a medicine for pain, like a Norco or Oxy, and that's on the high end, okay, for serious pain, one of the things that you're going to encounter is what? Constipation. So they're going to put you on a pericolates. Okay. If you're taking certain type of blood pressure medicines, like if they're putting you on a water pill, your body's going to kick out too much potassium. So now you got to take a potassium pill to go along with it. Okay. If you've got some type of medicines that you're taking for diabetes, you have to take something else to go along with it. So you may only be on 4 medicines, but you're taking another 4 medicines to counteract the different side effects for the medications. Okay. Hyperglycemia is also because it pushes your sugar up and weight gain and decreased absorption of vitamin D. So sometimes the people, when they're taking this, sometimes they may have to go to the vitamin D tablets that they're taking every week or something like that to go ahead and to make sure that they're getting that vitamin D absorption, because one of the things that we talked about in the slides, they tell you the vitamin D, you need to go out in the what? Sun. But if you've got lupus or something, now they're telling you you really shouldn't what? Be out in the sun without sunscreen. So all these other different things are happening and going on. Okay. Antimalarials, okay, are used in rheumatology practice. They've been along for a long time. And when the body begins to attack itself, it can mess with the joints and cause joint pain and cause deterioration. So your antimalarials are primarily used for like skin and joint manifestations of your SLE, okay, to go ahead and to counteract. And they're designed to show prevention of lupus flare-ups and preventing bone mass loss. So what came when you talk about anti-malarial drugs really came back to light 5 years ago. We heard about that. When we dealt with COVID, what was one of the drugs of choice that we heard that was helpful in the drug therapy? Okay, black with them. Okay, it's always been there forever. So, COVID was something else, just impacts people totally different. I had COVID twice. The first time I had COVID, I didn't have any symptoms. I just went to the doc one day to the ER. I think I got a little chest cold or something, so when you're in pharmacy, you figure like you can always just diagnose yourself, looking in the cabinet. I said, do I have any spared antibiotics at home and stuff? No, I guess I got to go to the doctor and get something. And went there and they did like a, pulse ox. It was like 93 and stuff. And they said, they did a COVID test. I came down, we're going to admit you. So I didn't have any other symptoms and stuff. I stayed in the hospital for 4 days. They gave me remdesivir for 4 days. I called it the super soldier serum and stuff because I was feeling great when they gave it to me. I was ready to run and stuff. But everybody, the doctors that checked me, they had totally different symptoms. One doctor had lost their taste, they lost their smell. Another doctor had their taste and their smell, but they had they were weak and they were tired and they were sleepy all the time. So everybody's body works different to a particular type of disease state of what hits them and what affects them. So those are the things that you have to watch for. So, but using, they were deciding to go ahead and to use Plaquenil as a therapy to go ahead and to treat COVID. They've been used in, like I said, rheumatology practice. Like I said, used for the skin and joint manifestations, stops the flare-ups, stops bone mass loss, and protects against irreversible organ damage. So that's one of the problems that happens with lupus when it begins to attack the body. So when we look at like an autoimmune disorder, okay, I'm sure everybody has probably been explained to what's happening and what's going on. The body is essentially turning on itself and it's attacking itself. Okay, so anything that's not supposed to be in the body recognizes as foreign and it's designed to go ahead and kill it and destroy it. Okay, that's how our body does it, heals itself. So what happens when the cells are there, but then the destroyer cells look at different things and they don't really recognize what's going on, then they begin to go ahead and get destroyed. And then what happens when your immune system gets too low, then you're now more at risk for different type of opportunistic infections. So then the goal is we have to go ahead and shut off the immune system. The problem with shutting off the immune system is now something that normally your body would fight off. Now it doesn't have the ability to do. And so that's why you have to go ahead and supplement, but come up with other different type of medications. So your antimalarials like Erlin or chloroquine, which has been out there, and then Plaquenil is the most preferred, drug of choice because one of the less side effects, it has the property that works as anti-inflammatory. It also works as an anti-thrombotic and platelet aggregation. One of the things that they studied when they talked about with COVID, we had never seen COVID before, never experienced. So we can go back later on and tell our grandkids and different things years ago. So I lived through the plague, So, but what they did and why people who were on like blood thinners had a better success rate with COVID because as they begin to study and do the studies and just looking at it, when they talked about like in the lungs, at first they were thinking that everybody's got pneumonia. It wasn't pneumonia, it was an irritation. Like in the slide, when the doctor talked earlier, how you're not supposed to, smoking different things because in your lungs you have like your cilia, different things, and they get stimulated and they produce mucus. Mucus are designed to go ahead and to pull things out of the body that are not supposed to be there in the lungs. But what was happening in the lungs, there was a lot of irritation that was going and excessive platelet aggregation that was going forward. So people, basically you get clots and different things, you can't bleed. So now the things now when they're treating COVID, they'll put them on different types of classes. They'll put them on the mobs, and they'll put them on like blood thinners and different things to go ahead and clear that out. So it's the same thing like with lupus. One of the things like with Plaquenil, it has that property. It reduces different type of cardiovascular risk factors like hyperlipidemia, diabetes, and improves the survival rates. And it delays the onset of renal damage and skin damage. Okay, so one of the things that we talked about from the dermatological standpoint, some of the different things that you see, they put that in combination to help reduce the risk. Okay. With antimalarials, there's a mild risk factor. Usually they're given, like if people go to other different countries, they'll put them on that particular medicine when they go, before they go out of the country and when they come back, just to make sure they're not transmitting or bringing anything back. One of the things with any type of medicines, doctors and physicians will always have different lab work to make sure that are done so they can make sure that renal functions and your liver are functioning like it's supposed to. You always have to watch with the liver with different enzymes, and like one of the main enzymes that they look at, cytochrome P450, is responsible for breaking down different things. So you have to watch with certain medicines because it will shut that off. Who likes grapefruit? Okay, grapefruit shuts off cytochrome P450. Okay, so one of the things you have to watch, like they would tell you with certain medicines, like if you're taking for certain medicines like blood pressure medicines or cholesterol medicines, to avoid grapefruit, because what it does, it shuts off that enzyme and then it's not able to break the drug down. And now instead of the drug being therapeutic, now it can be toxic. Okay. So different things like that. It's like, oh, you know, so, okay. And the biologic agents. Okay. I know my friends back there at AstraZeneca is like, yeah, this is us. Now you back there waiting and stuff. Okay. So monoclonal antibodies are referred to as MOBs. Okay. And these are a breakthrough of drugs. They came out years ago. These are prescribed for a lot of different things. So kind of look at MOBs, or monoclonal antibodies, as a designer drug. Okay. They use them to treat multiple sclerosis. They use them to treat other different disorders. So look at it like this. If you're sick, and if I take a particular medicine, it's going to work over the whole body, and it's going to kill off a whole different things that aren't supposed to be there, but it also may harm things that don't need to be touched or messed with. So what a MOB does, it goes and specifically creates an antibody that whatever that antigen response has caused in the body, it makes something specifically designed just for that. So they use it with cancers, they use it with MS, they use them for lupus, and then that way it can go ahead and kind of pinpoint, rather than just going in and just destroying everything or messing with a whole bunch of stuff. It focuses just right on that. So we heard him talking about earlier about how the B lymphocytes, okay? So the B lymphocyte stimulator is what contributes to the production of the autoantibodies, okay? And so there's those things that go in and just start destroying and wreaking havoc with the immune system. So it targets that particular lymphocyte, okay? And they target also certain cells involved in the immune response that lead to the inflammatory process of lupus, okay? Rather than working on your entire immune system. So that's why they are used, and that's why they're prescribed, okay? In MS, usually when people have multiple sclerosis or different things, sometimes they'll start what they used to start with certain medicines, and then they move up. Now what they do, they just go ahead and hit it right at the beginning, grab it, bring it under control, and then they can go ahead and maintain it with other different type of medications. Okay. So, okay. Isn't that your drug, Safnello? Is that you up there? See? Got you up there, see? No free advertising for you though. So okay. So those are the different medicines that are up there. So make sure you stop at the booth back there. These are some of the medicines that are out there that are used. And Synthekine is a company where they just basically were cleared by the FDA for a new drug application for a phase 1 study of a new combination drug. Okay, so it's going to treat I should have put it's going to treat SLE and ortho. You can probably help me with it. Ortho is forgetting, but it's used to treat 2 different type of lupuses. So basically what it is, instead of having the lymphocyte drainage, you don't have to go that particular route. So it just got approved in September. So that's, I don't know if that, I meant to catch the doctor when she was talking about the new studies that they're doing, the clinical trials, if that was one of the drugs that they were talking about, but it just got approved early this year. So there is hope. And one of the things that different things can pass certain phases. Drugs go through 3 stages, like a phase 1, phase 2, phase 3. But because of different pharmacy laws that are out there, like the Orphan Drug Act, it allows certain medicines to go ahead and bypass the red tape if they know that if they have a particular drug that's going to treat a particular type of medical condition and it's shown to have promise and favor, then they will go ahead and allow it to go through the clinical phases faster. We saw that 5 years ago with COVID. Okay, we came up with a vaccine and it didn't have to go through a lot of the chemical phases to go ahead and to go out. Okay, I'm good. Okay. All right. So these are some of the mobs that are out there. These are just a few, the monoclonal antibodies that are out there. Okay. Some of the things that you have to watch for with different type of biological agent, the risk, just with hypertension, sudden bleeding, poor wound healing, blood clots, and kidney damage. One of the things is always going to be poor wound healing sometimes, because when you suppress your immune system, it just takes your body a little bit longer to go through certain processes. So normally what would happen normally for a person to go ahead and recover quickly by going and taking other different type of medicines that suppress your immune system, you have to, it just takes a little bit longer. So no, there's always the risk sometimes of going out in public, going out in places where lots of people, something sometimes just as simple as, I want to go get in a hot tub somewhere and stuff. You can't do it and stuff because you have to watch for the risk of infections and bacteria and different things like that. Okay. And immunosuppressants, okay, are given. And we talked about this earlier. They're designed to reduce the activity of the immune system. The main challenge with immunosuppressants is, like I said earlier, it just makes your body more susceptible to opportunistic infections. Okay, so when your kids are around and they're sneezing and coughing and different things, you have to watch. Going out in public places with a lot of people, you have to watch that also. And people with lupus are more likely to experience infection and infection-related complications, just because with a lower immune system, it just takes them longer to recover. Okay. 2 things. One is weakened by the disease. One, because of attacks, and the medications that are also used to treat it. Okay. So it's kind of like a double hit. So it's a challenging thing because your body is turning on itself and it's okay, we're going to give you something that's going to go ahead and shut off your immune system so the body doesn't attack itself. Okay. But then at the same time, we go ahead and you can get colds or different things like yeast infections. You put you on antibiotic. Women are susceptible to yeast infections. Usually, if you go through a particular regimen of antibiotics, sometimes the doctor may give you like a diflucan or something like that to take at the end, because 9 times out of 10, you may develop that. If they have you on different steroids and different things like that, then there's a risk of you getting thrush and different things like that. So we give you medicine to go ahead and rinse your mouth off. So, okay. Some of different immunosuppressants, and these might look familiar to a lot of people. Any of these look familiar? Okay. Okay. All right. Imuran, Cellcept. Cellcept is given for organ transplant. Okay. So people that have like kidney or liver or heart or lungs, they give them Cellcept in the midst of a lot of other different medicines to basically shut the immune system down, to give it time so that way the body doesn't reject the organ that's there. Nero, Sandamoon, and Gengraft. Lumitrex or methotrexate, which is given also for cancer. Cyclophosphamide, this is one that was in the talk earlier. Cytoxin is anti-neoplastic agent, cancer agent, which can be very strong. Leukeran and your nitrogen mustards or mustargen are different medicines that are given. So sometimes in combination, there may be immunosuppressants. They may give them mobs. They may give them steroids. They may give them topicals. They may give them orals. So there may be a combination. Some people that have, that are here may only be on one medication. Some people may look and say, man, I'm on pretty much every slide that he's been through up here. And everybody's different just because of your genetic makeup, So one of the things like we look about pharmacogenomics and pharmacogenetic is, with different studies, they look with different classes of people and they look at some medicines that they know might not work in a particular class. So say if we can go ahead and pinpoint that African Americans, this medicine will work better than this particular medicine, then that's why sometimes that medicine is prescribed just for that particular class. And say, well, I know somebody else that has lupus or whatever. How come I'm not getting what they're getting, or how come I'm not getting that particular treatment, what they're getting? It's a couple of different factors. One, your disease state, okay? And then also just to look to see how that medicine is going to work and going to get the outcome. Okay. I see your hand. I see a couple of hands.
So I want to talk about, or I have a question about, and I kind of know the answer, but I want to get professional opinion.
Oh my goodness, professional opinion.
So I have portal vein thrombosis, so I have a tips that does the bypassing of the liver type of thing. And so one of the main struggle points with my physicians and I are the medications they give me, because I'm like, if the medication is supposed to metabolize in my liver and it's going by it's like, well, it goes to my brain and I'm like dizzy. And so I guess I'm just trying to understand. I know I have taken the medication to kind of help with that a little bit, but are there any classes of drugs that kind of handle that?
Which we even talk about for the mental or just
yeah, because I was diagnosed with hepatic encephalopathy, so I take Xifaxan.
Mm-hmm.
But is there anything else that another class of drug or something that can kind of help with that brain fog? Because it can affect me. So I got that fog going on. Then I got the lupus brain fog going on. Then I got the so I didn't know if there was something aside from just the Xifaxan or something else in that area that maybe you've heard of or help with that.
No, it's just that with what they're going with. Like you said, if they're looking at they're bypassing the certain things that they want to, if they're looking at trying to treat, they're looking at, just the metabolism. That's if you're bypassing that, and they also have to be watchful because certain medicine begins it's not getting metabolized and harm of different parts of the body. Because they're looking at the liver, but they're also watching the kidneys. They're also watching the heart. So that's why that could be a reason why they're probably hesitant to go ahead to go with a particular route or treatment. saw that hand and I saw that. You, yes, you, in purpose.
Yeah, so when it comes to pharmaceuticals or pharmacy drugs, like I saw one of the ones that I was on before, the Cytoxin, the chemo, very, very, very strong chemo. My problem with them is how are doctors supposed to give patients the facts about the side effects, like, or expect people to deal with that. Like I was throwing up constantly and, I feel like that's a soul killer drug and I'm like, I'll beat my maker before I take that again, and it's like, I was hoping you might touch on also the pain medications as far as pharmacy goes that we need because lupus warriors, we have excruciating pain and while we're hospitalized, they'll give us the max dosages or whatever to keep us calm, handling the pain. When we go home, we get discriminated against. We get told while we're in the hospital 30 times, don't sell these pills. So you give me 6 of them to take home. And I've dealt with discrimination. People want to pick up my medication from the pharmacies themselves. Like I want to sue them because the pharmacist was like, what do you need this medication for? Like, are they supposed to really be able to ask that in the way that they do? Those type of questions is what I have. I know that was a lot, but
It is the way,
that's what I
it is
face.
a whole.
And the discrimination really needs special pharmacies and pharmaceutical people to talk about what happens. That's if we have us look like drug fiends or something when we're in the most amazing pain you can think of.
It's unfortunate because of. All right, I'm on my soapbox now. Okay, so when you look at pain medicines, and you look at the prescribing of pain medicines, and a lot of the problems that are going on with. There were a couple movies out there. Anybody see Dope Stick?
Yes.
Huh? Yeah. Dope Stick was good. So when, certain pain medicines, when they're made and they were put out there, it's unfortunate that the numbers get screwed to go ahead and push it, and they didn't look at the long-term effects and the addiction that go along with it. So now it's the regulation that goes along with it. From a pharmacy standpoint, a lot of pharmacists really don't like dispensing a lot of pain meds because it puts them on the radar. Okay, because one of the things, like we said, like Wednesday, I have a board of pharmacy meeting and I sit on the discipline and sanctions committee. So I have 41 cases that I have to review where I'm going to decide whether the pharmacist or technician is going to keep their license or not because of diversion and different things like that. So they are afraid to go ahead and to keep dispensing a lot of different medications because if they fill too many prescriptions of medications, then they'll look at it as a pill medic. Okay. Now, as far as to kind of judge to say, why are you taking this? Why are you taking this? That's something that they really should not be saying. Okay. One of the things they look at too, like you look at a drug like a Norco, which is a combination of hydrocodone and acetaminophen. You have to watch because you got 5 milligrams of hydrocodone and you got 300 to 400 or 500 milligrams of acetaminophen. Max dose of acetaminophen is that your body used to be 4,000 milligrams. Now they lowered it to 3 because of liver toxicity. So the doctor writes a script, 1 to 2 tablets every 4 to 6 hours. Okay. Then they say doc's only gonna write for so many of those particular tablets, and they figure the patient should only be taking so many. But when you're in pain, you're in pain. In the hospital, they're going to hit you with a max dose because what you're going to do, they're going to bring your pain level down. Okay. Because other different symptoms are masked or going on because you're in pain. But you have to get the pain down so they can go ahead and do it. And the unfortunate thing when you leave the hospital, when it flares back up, it's like people with sickle cell. They're taking high doses of morphine. They're in pain. You're in pain. He's like, I don't want to hear anything else. I want this to go away. Okay. So on the doctor end, they're looking at the PDR, and they're studying this and this. But at the pharmacy standpoint, we're looking at, okay, what's the interaction, what's the contraindications? And if I'm taking this pain medicine with this other med, what's going to be the interaction or what's going to happen? Is it going to be more beneficial? Is it going to be more harmful? Or can we just go ahead and titrate down? And just because of the laws that are out there, they regulate also. It's unfortunate that people sometimes, when you come in with a pain medicine and they think that quote unquote you are a junkie, and everybody is not a junkie. And people that are legitimately in pain and need help and they need assistance and they need to be taken care of. And for some people, the only thing that they works for them is certain pain meds. Okay. I know some people that have lupus or MS and stuff, and they say only thing that works for them is marijuana. Okay. It's like not too far from here. And Antoinette Jameson, remember, used to be the newscaster on Channel 2. She stepped away from being a newscaster because of MS, and she was on TV and she was forgetting everything. So she said, I can no longer do this particular role, so she started her own company, Botanique. Okay. And, she said that's the only thing that really helps her. So what works for one person may not work for another person. And, when we're starting to talk about different type of treatments, the studies and different things are going forward more. I'm not an advocate for marijuana and stuff or anything. I just put it on my salad. No, I'm just joking. But the studies are going forward to see for certain type of treatments if it actually really works to help with certain things, so they can move away from certain type of pain medicines because of the addiction that goes along with it. If you start taking those heavy doses of those pain medicines, yes, they may work, but then the thing about it is stuff, you go with large doses, your body builds up a tolerance and stuff, and then you have to take more and more and more drug to get the same effect. And what's happening is not really getting effect. It's just that particular medicines are not hitting those particular receptors and binding like they're supposed to get that particular type of effect and result. Okay, in the back there.
I was diagnosed in 1990. And when I first was diagnosed, they hit me with a very high dosage of platinum and prednisone. So I've been on prednisone since 90. Very large dosage. And tapering, big flare. Large dosage to control that. Taper, and it's like a yo-yo effect. So now I'm down to 5 milligrams, and I can't go lower because I have a flare, and it's this silent flare. I have marks, which they're trying to go away, but I notice when I get that red ring around my mark, these are my these are my happy marks. Because if I notice a red ring, there's that flare coming, and then I'm like, ooh, I better take more prednisone because of that. Now I developed avascular necrosis in my hips, and I'm 53, and they want hip replacement. And I'm like, you guys see me wiggling in here, it's because of my hips. So now they're saying that avascular necrosis is in my hips and in my neck and shoulders because of the
bone loss.
Prednisone. And I can't get off the prednisone. And I'm like, well, when is it going to stop if I can't take this? And I'm the opposite of pain. I'm like, I don't want that pain medicine because I'm taking so much of this, I don't have. So I don't do that. And is there a holistic approach versus medication approach? Because I've also developed what's it called, medically induced diabetes. So I have the diabetes also because of so it's just like one thing after another.
From the holistic side, there are some things out there, but the only thing about holistic, they're not going to say they're not recommended, but like the studies have not really been there to really prove. And then they always have to watch and say, okay, if I'm going to try this, we take you off of these particular medicines and go with this. Well, everything just kind of spiked back up again. And then now you got to hit you with a larger gambit of medication to kind of suppress it and bring it back under control. Their goal of what they're trying to do is just to keep you on a particular dose to try and keep it maintained at a particular level where it's manageable. And then a flare will just require a moderate increase of certain medicines. So like if you're on prednisone 5 and you see a flare, what do you usually take it up to, about 20 or something, 20 or 10? Okay, so that's not bad. 10, going from 5 to 10 is not bad. Some people may have a flare and then they have to go back up to 50 and they go ahead and titrate all the way back down. Like some people that have like organ transplants and stuff.
That's what happens when it flares, I'm in the hospital, it's 50 or 100,
Mhm.
and then
Yeah,
it keeps
yeah.
down. So I'm in the hospital for like maybe a month or two because they're trying to ease that down.
Mhm.
And in the meantime, I have a high schooler.
Yeah.
And it's like, hey,
Mhm.
you dang if you do, you dang if you don't, you're stuck for this.
And I know that can be, I know that can be frustrating, you know, and I think one of the things too, and I'm about to wrap up because my time is up, you know, just the dealing with the medicines and the regimens can be frustrating, trying to find that sweet spot of what works the best. And like everybody is different. Like you said, if you know, like they're talking about hip replacement because your bones are deteriorating and stuff, everything. Do they have you like on a vitamin D or anything like that?
Vitamin D, too much of vitamin D, that's the calcium and it's going to fight.
Mm-hmm. So yeah, so that's the thing, and that's the frustrating part, and hopefully with like a lot of the new treatments that they're coming out with, that they can go ahead and come with that particular point that they can go ahead and eliminate it, suppress it, and then start weaning you off of the other different medications. Okay, all right. I don't think I had any questions in the queue or anything and stuff. Thank you for your. Oh, you gonna check?
Yeah, we'll just check, but let's give it up for Keith.
Okay.
Yeah, I think we're all good.
Okay. All right.
Thank you all so much for those great questions. Lunch should be here shortly. So we're going to take a quick 10-minute break. And then the plan is to have you all get your food, and then we will start the next presentation as close to 1 p.m. as we can. So thank you. Do what you need to do. For those on Zoom, like I said, we'll be back at 1 p.m. With another presentation.
At some point during their disease course. And what dry eye is just a condition in which the eyes aren't producing enough tears. That's often because of inflammation involving the lacrimal glands, which produce our tears and are located kind of at the top and the sides of the eyes. Or the tears that are being produced just really aren't high quality. So most of us know that tears are obviously made up of water, but there are a lot of other important components to tears, including oils that are secreted from the glands in our eyelids, as well as mucus secreted from the sort of inside of the eyelids, the parts that we call the conjunctiva. And so tears really require all three of those components: water, oil, and mucus, to keep them adherent to the surface of the eye and to keep the eye well lubricated. So it's not just water. And that's why sometimes when people have dry eye, they actually produce too much water. It's their body's response to the eye dryness. They'll also have a burning and irritation sensation. It can be extremely painful. The eyes will feel gritty and sandy, which kind of makes sense if you see this picture, right? Instead of having a nice clear surface to the picture of the cornea, the surface of the cornea looks bumpy, and you can imagine how that feels. There's also eye redness is really common with dry eye, blurry vision, double vision. But it's important to know that dry eye is really a pretty treatable condition for most folks, but sometimes you have to try a couple different things. So there's artificial tears, which you can just buy over the counter. I always tell my patients to start, we don't have any evidence that one works better than another. I choose what's on sale and stick with that. But some people do feel like certain types and certain brands do work better for them in particular. You'll find them with or without preservative. And again, the ones without preservative are going to be more expensive and not necessary for everyone. So start with the ones with preservative unless it's causing you any kind of additional burning or irritation, and then switch to the more expensive preservative free if needed. And then some people need a topical anti-inflammatory drop. These are drugs like cyclosporin, which also go by trade name of Restasis or Xiidra. And there's some other medicines that people use. Sometimes we use things called serum tears to treat dry eye, or what are called punctal plugs, where we actually stick a dissolvable plug in the tear duct to keep it from draining and really keep the tear lake higher in the eye. But again, if you're having these kinds of symptoms, see your doctor, keep working with them. It's often something that's pretty addressable, but sometimes you need to have ongoing treatment. All right, so the second thing that can impact really the front of the eye is something we call episcleritis or scleritis. And so we've all at some point in our lives had red eyes, whether, you didn't sleep well or you're feeling under the weather or what have you. But this is a really specific kind of red eye where really a section of the eye becomes very red and extremely painful. So rather than having the entire eye red, it's usually just a portion of the eye that is red. Again, incredibly painful. It's a sign that there's inflammation, either in that clear coating over the eye, we call the conjunctiva, or there's inflammation in the white of the eye. And so in these cases, you do need to get an eye exam immediately. Some of these cases need to be treated with steroids or other immunosuppressants. And if they don't get treated, you can end up with eye inflammation, and it can really impact the vision. So it's important to get it looked at. If we move a step back to the retina, I think in some of the earlier talks, you talked about how sometimes lupus can involve blood vessels of different organs. It's no different with the eye. So the blood vessels in the eye, and in particular the retina, are susceptible to inflammation. And when the blood vessels become inflamed, they will plug up and you can lose blood flow to parts of the retina. And those are essentially like small strokes, if you will, at the back of the eye. This is often a marker that the lupus is severe and often needs to be addressed with high dose systemic treatments, very similar to a lot of the immunosuppressant agents that the prior speaker just went over. And that's really the aim, is getting things under control systemically. There's often not a lot we can do for the eye itself. Sometimes if these strokes lead to a lot of swelling at the back of the eye, we will do eye injections where we essentially inject certain agents that help to get rid of some of that swelling, especially if it looks like it's getting near to the parts of the eye, like the fovea and the macula, where we actually focus our vision. It is possible that you might not have any symptoms and this can go on. So sometimes doctors, your rheumatologist might recommend that you see an eye doctor just to look for this, to make sure that the eye is overall healthy. In other people, if a blood vessel plugs up, you can get sudden vision loss very quickly at the back of the eye. So if you're having new symptoms, blurry vision, spots in the vision that are persistent, you need to see an eye doctor. All right, so if we move another step now, we're behind the eye and we're talking about the optic nerve. The most common way that lupus can affect the optic nerve is by causing inflammation. So I have this little cartoon here at the top, and the red spot, behind the eye is supposed to represent kind of inflammation that can occur anywhere along that optic nerve, and will often cause very painful vision loss. And the vision typically declines over days. Often people will have pain first, then they notice the vision loss. The eye itself will not be red. So, the outside of the eye will look normal. And that's because, again, the inflammation is really going on behind the eye. It's in the orbit itself. People will have pain with eye movement because that optic nerve is getting stretched as the eye moves around to scan the environment. You might notice loss of color vision, which is one of the hallmarks that the optic nerve is actually involved. So in particular, reds will look pink or orange. They can even, people will say like they can't distinguish the stoplights. That's a pretty common symptom in folks with optic neuritis. When your doctor takes a look at the back, they might notice optic nerve swelling, and that's just where the optic nerve is entering the back of the eye. It can look swollen. It doesn't always look swollen though. So you can have a normal eye exam and still have optic neuritis. So eye doctors or your rheumatologist will almost always order MRI in these cases. That's this picture here at the bottom. We have a right eye and a left eye, and you can see right behind the eye, there is this white structure. This is actually the optic nerve, and it's enhancing because it's inflamed. And you see on the right side how that optic nerve, you just see sort of a gray line, which is just the normal optic nerve color. This is something that has to be treated with high-dose steroids, typically an admission to the hospital for intravenous steroids for 3 to 5 days. Often you'll remain on steroids, high doses, and taper down over a number of weeks. Sometimes we will use very high-dose oral steroids instead. Again, those could be at doses as high as, believe it or not, about 1,250 milligrams of oral prednisone a day. Or even sometimes a little bit lower than that, like 500. It just really depends on the patient. And so last, when we think about the eye, it is possible to get to experience pain in the eyes and to have a totally normal eye exam, because lupus has essentially kind of flipped on some of those pain circuits in the brain. And so in those cases, often, just like you could get pain in other parts of the body without having a lot of inflammation, you can get pain, you can experience pain in the eyes in a similar manner. And so folks like this will often, it's not just eye pain, but they'll experience more kind of widespread pain in other places of the body, might also be experiencing other things, like that sort of fogginess feeling, sleep problems, maybe mood is off. And really talking to, your rheumatologist about these symptoms, or your doctor is important after you get an eye exam if your eye doctor is not really seeing anything in particular related to lupus. All right, so lupus can affect the visual system in the brain. So as we said, after vision is really collected in the eye, it moves through the optic nerve, and the optic nerve plugs the eye essentially into the brain. And all that information has to be carried all the way through the brain to the back of the brain, where we actually process our vision in the occipital lobe. So if lupus is affecting parts of the brain, whether it's, blood vessels, or you have essentially a neurologic involvement of your lupus. In those cases, if it involves those visual pathways or the back of the brain where we process vision, you can get vision loss, typically on one side of the vision, one side of your world, as we say. You can also get inflammation that involves the coating of the brain that we call the meninges, and the fluid that helps to cushion that brain. And it makes it hard for the fluid to drain away. And sometimes we will see as a result that the pressure gets too high in the head. People can experience a lot of headaches. You can get swelling of the optic nerves in response to that. And when we see that, it's really important to, again, for us, these are concerning things that we communicate with the rheumatologist about, helping to get lupus under control and using additional medicines to try to lower the pressure in the head to preserve visual function. So it's not just lupus that can affect the eyes and our visual system, but the medicines can also affect the eyes and the visual system. So I know steroids are obviously very common. A lot of folks with lupus are on steroids, and steroids can also increase the pressure in the eye. So increased eye pressure is glaucoma. And unfortunately, for most folks, there aren't a lot of symptoms. And I say unfortunately because that means sometimes we don't really think about getting our eyes checked for the pressure issues. But over time, this can lead to vision loss, and particularly at the sides of the vision. If you have glaucoma and are taking steroids, we think you might be a little bit more susceptible to having higher pressures because of steroids. So it's really important to follow closely with an eye doctor and make sure that they're following your eye pressures and are treating appropriately, because we do have a lot of medications that can lower eye pressures and keep things under control. So it doesn't mean that you need to necessarily come off the steroids if it's working well for your lupus, or you need it to keep lupus under control, but you just need to make sure that you're getting actually screened for glaucoma or monitored if you already have glaucoma. Steroids can also sometimes make cataracts progress more quickly. They can progress over weeks to months rather than years because of the steroids. And so cataracts are essentially just cloudiness that develops of the natural lens. It is, as I tell my patients, it's part of birthdays. With birthdays come cataracts. So it is a very natural thing that most people will develop at some point in their lives. However, if you're taking steroids chronically sometimes, or you have to go on to high doses of steroids, it can make cataracts progress much more quickly. So just be aware of that. You might experience things like blurry vision, a lot of halos or starbursts around lights, difficulty driving at night. And often we just watch it, especially if glasses are sufficient to correct the vision. But once you get to a point that your night vision is impaired, glasses aren't working anymore, then it's usually time to think about surgery. So steroids can also affect the back of the eye. So you can have a steroid-induced diabetes, or medically induced diabetes, sometimes it's called. And so just like any diabetes, you can get diabetic changes at the back of the eye with bleeding and swelling and things that can occur. So it's really important that you're getting annual eye exams if you do have diabetes as a result of steroid use. And then hydroxychloroquine is a medication that's often used for folks with lupus. And we have specific screening guidelines regarding lupus, which we will go over in just a moment. But in general, hydroxychloroquine can impact the retina and the photoreceptors at the back of the eye. And so that folks will experience blurry vision, spots in the vision. And it's really mostly dependent on the dose of hydroxychloroquine that you're on and the amount of time that you've been on the medication. But we think other things could increase your risk of developing retina changes or retinopathy, including kidney problems, pre-existing retinal issues, and some of chemotherapies that we use, in particular tamoxifen, which is used for breast cancer. So last, let's end with some screening. So this is just in general for the general population, what we typically recommend for screening. And, once you hit the age of 65, you really should be getting an eye exam every year. Sometimes we say every 2 years if you really aren't having any issues whatsoever. If you do have a family history of glaucoma, or you have glaucoma, you need to be you'll be getting exams typically multiple times per year. And if you have diabetes, at least once a year, sometimes more so if it's really impacting your vision. And last, I just want to end with screening for folks who do take Plaquenil or hydroxychloroquine. So you need to get an eye exam when you start the medication, and that's so we can screen for retina problems that might put you at risk for developing retinal toxicity. And then if you don't have any risk factors, if you're on a good dose, an appropriate dose for your body weight, then we typically start screening at the 5-year mark, and you'll do that every year. Your doctor will do something called an OCT, which is a really special picture of the back of the eye, as well as a visual field test. to essentially monitor. And they might do other tests like ERGs if they're concerned that plaquenil is actually impacting your visual function. If you do have risk factors, they'll probably want to see it more often. Every 6 months to every year is not uncommon. I'll just leave you with some information. If you are in need of eye care provider, we have satellites across Southeast Michigan. Obviously, there's also a lot of great other eye care providers in the area as well. And I'm happy to take any questions folks have.
Thank you, Dr. Delott. Yeah, round of applause. We'll pause for about 5 minutes. Anybody have questions in the room or on Zoom, feel free to raise your hand or put them in the chat. We have a question in the room.
Thank you for the presentation, but why is funks?
1 second. Can you hear that okay? Dr. Delott?
I heard, thank you for the presentation. Yeah, so I think I can hear pretty well.
Okay, great. Can you, it's funks, F-U?
Fuchs? Yeah.
Is that like cataract? Is that lupus aggravated? Can you explain that a little more for me, please?
Yeah, sure. So Fuchs dystrophy, for folks who aren't familiar, it's basically a condition that affects the inner layer of the cornea instead of the outer layer of the cornea. And it causes these sort of, you can almost think of like sort of little bubbles on the inside of the cornea. So Fuchs is not typically, caused by lupus. But sometimes inflammation and things can aggravate Fuchs, and but it's not directly a cause from lupus, but it can absolutely impact your vision and be really troublesome, as you may experience.
Thank you. Any other questions in the room? I didn't see anything pop up in the chat. I see 2 more in the room. Go ahead. I'm in the green. In fact.
So I thought it was interesting that, it said glaucoma from steroids, because I was diagnosed with kind of, I call it almost glaucoma, like the pressure in my eye is really high, but I have any vision loss. And so, a lot of my treatment sometimes, like a recent treatment, was like, the high dose steroid therapy. So I do see an ophthalmologist yearly. So so when I'm getting steroids, is it okay as long as I'm like seeing the ophthalmologist yearly? Like, did that kind of handle some of the concern, or should I just kind of be like, oh, I'm going to avoid steroids at all costs?
Yeah, that's a fantastic question. So most of the time, the issues with glaucoma are when the pressures remain high for long periods of time. That's when you'll start to develop vision loss. And there are folks like you where you could have high pressures, no vision loss. Some people have optic nerves where you think they might have glaucoma, but they don't have high pressure. So it can kind of go both ways. I would say if you're getting high dose steroids and, this is just for a few days, it's probably not something to be concerned about. But if you're going to be on steroids for weeks, then I would say it's worthwhile. Then you should touch base with your eye doctor, because they might actually put you on an eye drop to keep those pressures lower during the time that you're on the steroids. But I wouldn't. It's a treatable. Eye pressures are a treatable thing. So so you don't have to necessarily avoid steroids for that reason. You just need to know that if you're going to be on them longer term, you should check in with your eye doctor.
Thank you.
Thank you. We have time for one more question here in the room. Go ahead.
Hi, I had a question. I know with the lupus medication, they recommend getting your eye exam 1 every 2 years. How would being on that medication affect maybe getting LASIK?
Yeah, so good question. And so you're referring to the Plaquenil medication, I'm assuming, correct?
Correct.
Okay. Yeah, so it doesn't actually impact getting LASIK at all. LASIK is a surgery that we do of the cornea, and we essentially kind of shave down the cornea or change the curvature of the cornea. And so you can absolutely get LASIK while you're using Plaquenil. Plaquenil purely impacts the retina in the back of the eye, that photoreceptor layer of the retina.
Okay, thank you.
Yep.
Okay, let's give it up for Dr. Delott.
Thank you all.
Okay, now the food is here. Lunch is here. We can eat finally. We're gonna break for about 15 minutes for lunch, so be sure to get yourself some food, and then it's totally okay if you're still eating when we start up the next presentation. But we plan to get started at roughly 1:45, 1:50. So help yourselves to some food, please. Thank you. I know there's a couple more people getting, but we are going to get started. Okay, thank you all so much for your patience today. I hope you're enjoying the long-awaited lunch. Next, we're going to hear from Dominique Kinnett-Hopkins about physical activity and physical function with lupus. Dr. Kinnett-Hopkins is an assistant professor of applied exercise science and is the director of the Translational Physical Activity Laboratory. Please welcome Dr. Kinnett-Hopkins.
Thank you so much for having me today. And I just want to give a special shout out to Tiffani. I don't know if you remember, but last year at the conference, you met with me after and asked more about physical activity and exercise. And that really spurred me coming to present at this year's conference. So thank you. And thank you for the introduction. So today I'd like to talk to you a little bit about what physical activity and exercise are, the benefits and barriers that we often see with exercise, the international guidelines, what are the recommendations? What are we trying to help people to achieve? And then a little bit about our lab, the Translational Physical Activity Laboratory. I'm going to talk about some of the research that we've done because that's how we've translated what as scientists we've said we need to see done to help improve health to ways that we help people in the community adopt these behaviors. So I want to talk about some of our programs and give more tangible steps to this is if you wanted to adopt exercise tomorrow, where you could start. So physical activity and exercise are often thought of as one and the same, but there is a very important distinction between physical activity and exercise, and that is that exercise is a subset of physical activity. So physical activity is any bodily movement that we do, whereas exercise is targeted, it's planned, it's repetitive, and it's done with the goal of improving health. What's really important there in that distinction is intentionality. Why am I moving my body in this way? And that really helps us to know, am I doing physical activity or am I doing exercise? Some of the things that we can show as examples to clarify that physical activity can be doing your household chores, can be gardening, using a standing desk, occupational tasks, the ways that you move your body to do your job, or walking the dog, which often people are like, oh, I'm going to go walk the dog and that's my exercise. I'm like, the goal there is that your dog doesn't go to the bathroom in your house. So maybe how do we make that an exercise activity? Brisk walking is something that we can do for exercise, cycling, water aerobics, dancing, yoga, Pilates, and strength training. And just another plug for the recurring monthly yoga series that is hosted. And so it's a way that if you're interested in participating in yoga, you should follow up with Rachel about. But there are different types of activities that fall into here. So my lab specializes in these two. We have aerobic activities. Those are the ones you think about that get your heart pumping, right? You're breathing faster when we're walking, when we're swimming. And then we have strength training. And those are the ones that make your muscles stronger by lifting weights or using resistance. That form of resistance doesn't have to be in the form of resistance bands. It can be with your body weight as the way that you make your body stronger. Some other types of activities that are important for everyone is our flexibility. So helping your muscles and your joints move more easily by gently stretching them. And then balance. We really want to think about ways to improve our ability to stay steady so that we prevent our fall risk. Now, here's where I get to nerd out a little bit because exercise is like a magical world. There's so many great things that can happen from participating. So in the literature, we see that when people engage in regular exercise, and I'm making that distinction that just acute bouts can help in a short term, but in general, to see overall improvements in the way that your symptoms manifest, we need that recurring, consistent schedule of exercise. We do see changes in fatigue, where we see lessening of fatigue, decreases in anxiety, decreases in pain, and pain interference, specifically the ways in which pain interferes with your day, depression, and cardiovascular disease risk. Some of the other exciting benefits about physical activity and exercise are that it improves your physical function. We see greater aerobic capacity and our endurance, being able to do things for longer, improves your overall general health, your sleep, and your quality of life. And I think something that was really interesting that Dr. Kahlenberg said this morning is how important sleep is. And so exercising can actually help improve that quality of sleep so that you wake up being more refreshed. So if we know exercise is great, what gets in the way? And I feel like I could open a scroll of a never-ending list of the things that get in the way. But we'll talk about some common barriers now. One of the most commonly reported ones is lack of time. We all are busy. We have lots of competing interests to exercise, and it's really hard to make the time. And so that's just the reality of having to, when you say yes to exercise, you're inevitably saying no to something, or no to something else. And so where is that cost benefit ratio for you? Fatigue, right? Experiencing tiredness sounds really daunting to move your body when I already feel so tired. And it's this balance of, well, I know that if I did it, I might feel better, but that hump and that kind of just getting your body into action is challenging. Rachel gave a great talk really talking about inequities. We think about that too with access. Where are the facilities located? If that's, group fitness is something that you prefer to do you have access to those things? Do you have access to the equipment that you need? Do you have access to the knowledge that you need to be able to do those? And sometimes it can be really expensive to get the equipment that you need or the memberships. Insurance has some programs for things like silver sneakers. So if you are of a certain age, you can get memberships to gyms, and that's helpful through your insurance or discounted rates. But we don't really see that for other conditions and for younger individuals. And so that can also be a barrier. And then finally, one of the other common reported barriers that we see is a lack of knowledge about where to start or what to do. So let's talk about it a little bit more specifically related to lupus. And so when we think about the symptoms that we've talked a lot about today that happen with lupus, those can also be barriers to engaging in physical activity and exercise. And so we want to make sure that we are addressing, approaching exercise in an appropriate way, in a gradual way, to prevent exacerbating any symptoms that might occur. There was a really interesting study done that talked about fear around exercise. And so there are 50 people who were interviewed about exercise and kind of what they like to do about it and what they thought prevented them from doing. And fear was one of the big recurring themes that we talked about, or was talked about. Fear of getting injured, fear of causing a flare, fear of doing it incorrectly. And so that is something that we try to do in our lab, is to take away that fear and try and give empowerment to be able to approach exercise more confidently. And then the last bit, because I know that we're here with a lot of caregivers today, is judgment. And so in some of my research, I work with several different autoimmune conditions, and this idea of invisible symptoms comes up a lot. And so I might be feeling something in my body and no one else knows that. And what I was able to do last week is different than what I can do today, and will be different than what I can do next week. And the people around us have a lot of influence in the way that we interact with exercise. So I'm recalling a story from someone that I interviewed about going on a hike with her family. She really wanted to join them, but she knew that if she did, then they would expect her kids would expect her to go every week, and she couldn't commit to that, and she didn't want to disappoint them. So there's ways as caregivers or support teams that we can think about how we are flexible and understand the variation of how symptoms might manifest to be able to provide support when people can engage and when people can't. Okay, so now for the fun education portion. What are we trying to get you guys to do? What do I mean when I say engage in physical activity and exercise? The American College of Sport Medicine and the CDC recommend 150 minutes of moderate intensity aerobic exercise or activity every week. that every week is what's really important here. That doesn't mean you have to think about exercises. I have to work out for a whole hour. I have to work out for a whole 30 minutes. It could be, I did 5 minutes this morning. I did 7 minutes over lunch. I did 5 more minutes before I went to bed. As long as by the end of my week, I'm getting around that 150, then I'm achieving guidelines. And these are physical activity guidelines at a moderate intensity. So that big distinction that I made between physical activity and exercise, this is where we are failing at a field a little bit, because moderate aerobic activity is really more of an exercise guideline. And so we are trying to change the narrative to make that a little bit more clear. So there are ways that you can reach these guidelines by general movement, as long as your heart rate's getting up. But we really want to think about reaching these guidelines in terms of dedicated exercise, because it's intentional and done for the benefit of improving your health. Additionally, we are looking at doing muscle strengthening exercises, resistance training 2 times per week. And that's targeting your large muscle groups. So some people like to split that up and think about, I do a lower body day, I do an upper body day, and I might do a core day, or I might do a lower body day, a push day, where I might be working on my back muscles, or a pull day where I might be focusing on maybe my biceps and things like that. All right. Earlier this year, there was a paper published, and I was fortunate enough to be surrounded with 27 other experts around the world on creating the physical activity guidelines for lupus specifically. So those guidelines that I shared with you earlier are chronic condition guidelines in general, and there were not any really developed for lupus specifically. And so this QR code takes you to the original paper. I didn't want to go through all 15 of the recommendations here, but if it's something you're interested in learning more about, you can access that article there. The big takeaways that I'd like to discuss with you is that everyone with lupus and without lupus should engage in physical activity and exercise, okay? So why is that important? Years ago, as soon as someone was diagnosed with lupus, physicians would say, don't move in an exercise type of way. You need to sit still, you're going to exacerbate your symptoms. And so there is this myth that we're trying to get through by showing more and more evidence of the safety of exercise, so that we can change that narrative. And so this is one of our big kind of ways that we've disseminated and shared knowledge about physical activity and exercise is something everyone should engage in. It should be personalized and should be adopted gradually. You don't need to decide tomorrow that everything that you're doing today has to change and you have to go all in on this new lifestyle behavior. Oftentimes, that's not a way that we can improve consistent exercise engagement. So we want to make sure we're adopting habits in a way that are sustainable. Modifications due to symptoms or flares should be taken. And this is where healthcare team and providers can really come in to be able to help you learn how to manage when you types of exercise that you might want to do if you experience sun sensitivity, right? So what are things that we can do as an alternative to being outdoors? Or what kind of clothing should I wear to make sure that I'm protecting myself? Things like that. So each session should include a warm up and cool down. So that's something that we want to think about as well. We don't want to just go into moderate intensity exercise right away. We want to make sure we're giving ourselves and our bodies a primer into that. And then lastly, we want to encourage you to talk to your medical care team about exercise. Unfortunately, in medical school, doctors don't receive a lot of education about exercise, but they do have the power of referral, and physical therapists learn a lot about exercise. And that is a great resource that can be leveraged for not just going to physical therapy when you have a functional or mobility impairment, but going to get education about exercise. And I'll talk a little bit about one of our studies where we are promoting a proactive version of physical therapy for that reason exactly. What I wanted to touch on next were some common questions that I get when I talk about exercise. And so how do I know if the soreness I'm feeling is normal? With lupus, pain is a common symptom. So how do I know the difference between what's expected from engaging in exercise that's safe and what's not? So I want to bring your attention to this thing, which has always been a joke with me being a kinesiologist, and my name is Dominique and I go by Dom, but it's delayed onset muscle soreness, right? So it's what we expect to happen from engaging in strengthening exercises. And so this typically happens 1 to 3 days post-exercise. So if I decided that I was doing an exercise and I was targeting my biceps, if 3 days later I still felt soreness there, that's normal. If I felt soreness in my legs, that's not normal. I did not work out my legs. That's what you want to think about as the difference of, is this Dom's or is it not? If you are having a flare or mild to high pain, opt for mild exercise or resting. Okay, so this is not the time to go for what you had scheduled to do if you're experiencing these things. You really want to be able to be responsive to the signals your body is telling you and adjust accordingly. But what I do want to say is that because pain is something that's experienced all the time, the guidance for exercise engagement is if when you're engaging in exercise, your pain is not increasing and it is staying the same, then you're good to go. If you notice an increase in pain with exercise, you should stop doing that exercise. And that's when you want to go in and check with a professional to figure out a tailored way to be able to engage in exercise again that doesn't exacerbate your pain symptoms. Another question I get a lot, which is met with a lot of frustration. I feel like people come to me and they say this and they're mad, and I get it because it's confusing. What the heck does listen to your body even mean, right? And it's hard because there's not a good answer for it, and I will try to give you one, but it's not going to be sufficient. So we're just starting there with the bar on the floor. But what I want you to think about is recognizing your limits on any given day. You are looking to maybe an expert to give you guidance on this, but you are also the expert, right? You know your body, and that's where this part comes in that no one can really tell you. So recognizing your limits on any given day, how do I check in with myself in the morning or before a session to say, what is my capacity and can I do that? You want to monitor your symptoms before, during, and after exercise. So something that we think about when you're adopting a new exercise regimen is that your body is now going to maybe do something it hasn't done in a long time or ever. And so take inventory. How is my joint stiffness before I do this? Midway through my movement, how is my joint stiffness feeling now? After, how's it feeling? And then after you've done that for, say, a few weeks, do you notice patterns? Can you say, well, you know, before and during, it doesn't feel so great, but I feel some relief after. Well, that's kind of exciting. You know, that's also best case scenario there. So we want to make sure we're paying attention to how our symptoms might change with this behavior. We want to avoid a push through mentality. A lot of us have a lot of pressure to be excellent all the time, and that we have to feel we have a strong sense of integrity, but integrity is also honoring yourself. And so if you feel that, you know, I may have committed to doing this thing with a friend, we decided we were going to walk 2 miles and all I have is a half mile today, don't push through that extra mile and a half. We don't want to put you into a situation where you're risking your health for something that's not necessary. And then finally, in that same vein, is be flexible with your exercise routine. So something that I say often is don't should yourself, right? So we're not sitting here saying, oh, I should do this. I should do this. I said I was going to do this. Be flexible. Know that you are committed to the change and you will find somewhere else to do that. The last question that I get often, but on the caregiver side, is really thinking about how can I support someone? And so accountability partners. My girlfriends and I, we're going on a trip in January. It's my 7 of us from college. And we're like, we want to make sure we're holding ourselves accountable to exercise before we go to Jamaica. And we have a group chat and we're all saying, okay, we said we're going to do at least 30 minutes of movement, right? So now everybody's checking in every day. And I will tell you, when it was 11:30 at night and I was like, this has been a long day, I don't really want to go on my bike. That accountability group kept me doing it. So those are kinds of things that you can facilitate and do with your friends to make sure that you have support. You want to celebrate your small wins, right? So small and big wins. Oftentimes we have like this big idea of what's worthy, and everything that we do is worthy and exciting. So celebrate those, take the moment to do that and champion each other. Want to be flexible and adaptive, as I mentioned, right? So if you thinking about that judgment and that quote I shared from one of our qualitative interviews, be flexible, be adaptive, be a good support person. Don't feel and be another pressure point, because there's enough of that shoulding and mentality in our head. Encourage pacing and rest, but also support autonomy, right? So you also don't want to be limiting people from engaging, and you don't want to kind of control someone's movement. So you really want to defer to them as the expert of themselves. So those are my takeaways from, in general, the benefits of physical activity and exercise, and kind of just a better understanding of what it is. And so we're going to move now into some of our research. And I'm so excited to see some Moves alum in the room. But this was a study that we did motivating individuals with lupus to exercise. It was a 4-month home-based exercise program with the support of a motivational interviewing coach and Fitbits. And so we developed 3 progressions to reaching those physical activity guidelines over the course of 4 months. During an orientation call with me, we kind of brainstormed ways that you wanted to integrate these movements and your experience with exercise in the past, and also what your commitments looked like in the future to see what's the best way to integrate this into your life. So there was a green, blue, and orange group. The green group is what we often recommended. It's a slower buildup. You reach those guidelines after the 4 months or on your last week of the program. And then we had a blue and an orange group, which met those guidelines at week 13 and 10. So what does it look like here? So we'll jump over. This is the guidelines that we gave for individuals to adopt an exercise behavior. What I think is most important is no matter the intensity of which you're going, when you adopt a new exercise behavior, start small and grow. So you see each week, no matter what group you were in, you started at 10 minutes of aerobic training twice a week. Okay. And then after that, the programs start to vary in how fast the duration increased and how often the frequency increased. So I'm going to go over here to the screen section, and you'll see that we start off with 10 minutes of 2 times a week, but by the end of the program, people are doing 30 minutes 5 times a week. Now that is what worked for this study. Some people don't have 5 days to commit 30 minutes. And so they're like, I'd rather do a 60 or 50-minute session. And we would work personalized with them to adopt those behaviors over time. Regarding resistance training, I want you to see the progression there as well. So we did 1 set of 10 repetitions for 5 exercises. The best way I have to explain how to do that is to go backwards. We do 5 exercises, 10 times each, and we did that 1 time. We look at the bottom row here, week 16. We have 2 sets of 15 repetitions for 10 exercises. What does that mean? We're doing 10 exercises, 15 times each, and we're doing all of that twice. So that's how you would read a resistance training program. This is one of the ways that we help people over the course of 4 months adopt that behavior. One of the things I found really fun and shocking that I would always find myself saying in orientation, as a researcher, you really want to make sure people meet the milestones of your project, because that's how you make sure that you have fidelity in your study, right? That they're doing what you've prescribed so you can know if you've made a difference. And without fail, out of my mouth, and I mean it wholeheartedly, I would say, I don't actually care if you reach these guidelines by the end of the program. What's more important for me is that you've learned how to adopt these behaviors. And so if it's that you are at the equivalent of week 9 at week 16, that is a win in my book, right? So getting the exact number of movement was not my goal. Learning how to adopt this behavior was my goal. And so we had 28 people who were in this study. It was a small pilot study before we sought out additional funding. They were randomized to the control group or the intervention. And we found that fatigue and physical function were significantly improved, and those were sustained 2 months after the intervention ended. So the intervention was 4 months. We checked back in with people at 6 months, and we saw those same decreases over time. We also saw trends of improvement in depression and anxiety. This significant finding was exciting because we had such a small sample. You don't typically expect to find significance in this case. What we were hoping is let's find some trends, get somebody to give us a big check so we can do a big study and include more people and really kind of establish the evidence of this. But this is exciting, and so we're currently pursuing additional funding to bring this back up with a larger cohort. Now, my bone to pick with this in studies like this is grant funding. This was funded by a grant, which was lovely, but now that the grant funding period's over, we don't have as much time to be able to integrate that into the real world without sustained funding. And so PEDAL is a study we have where we use physical therapy to address this problem. Restorative physical therapy there in the middle. I'm going a little faster because I got the sign. Restorative physical therapy there in the middle is what you think of when you go to PT. You have an impairment, you want help to fix it. You go 2 to 3 times a week for up to 12 weeks. Consultative therapy is what we've developed here and modeled it off of a successful program in Parkinson's disease, where you go to a PT 1 to 6 times over 6 months. So about once a month for that period of time. And we work towards those same kinds of guidelines, but we just kind of rebranded them and took the advice that we got from interviews from people who participated in moves to make it more approachable and acceptable.
And so here we have levels, right? So your level 1 is 5 to 20 minutes of self-reported moderate intensity exercise. And what's helpful there is that you work with the physical therapist to see where in there you best should start, and you move forward. The second part is a strength training where we start at 15 minutes and then make our way over to the end of the goal, which is 30 minutes. This last piece that I'll share here before we go to Q&A is the rate of perceived exertion scale. This is how you measure how hard you're working. This is a modified version, so it's on 1 to 10, but it correlates with expected heart rate. And so green is goals, green is good. That's what we're hoping for. We think about light, that 2 to 3 range, how you typically move into your life is what you'd say. When we say what's self-reported moderate activity, we're thinking about that 4 range where you're breathing a little bit heavily, but you feel like you could keep doing it. Okay, I'm going to pause there for questions. Yes, thank you. Yes.
So, you can have like physical therapy, you got, the regular exercise. And then you also have like, I guess, specialty specific, like, for example, like cardiovascular. They call that rehab.
Yes.
So like how, I guess my question is, because I have something going on with my heart and something going on with my mouth.
Okay.
And so I get a lot of, well, over here and over there. Is there like a code or a preferred physical therapy maybe help kind of with that whole body type of exercise plan, or with like just going maybe with like cardiology? I guess I'm finding a hard time making sure that I'm covered on all my conditions.
Yeah, no, it's a good point. In context with things that were shared earlier today, that is kind of a loaded question for me to give a great answer to. But what I would say is cardiology is a great avenue. So there are things in some cardiac rehab programs that allow for people to come in and do training. So I know at Michigan, we had like a cardiovascular fitness center that was associated with our cardiac rehab program. And so something like that would be great. I actually have Melissa over here, one of our graduate students who is an exercise physiologist who worked in our cardiac rehab in Ann Arbor. So if you had any questions, maybe after you could chat with her a little bit about that. But I would say the best thing about those programs is you're doing those exercises while being monitored by someone like Melissa. And so if you have worries about engaging those exercises independently, that's a protected space where you have the infrastructure to support kind of learning how to do that with your body. Physical therapists are also great to be able to help in a more generalized way. There are some who have an affinity for cardiovascular. I work with a lot of neurologic physical therapists. And so that specialty and disease specific specialty helps to tailor for common symptoms. Our PEDAL study that I mentioned, I work with a physical therapist who's been trained in lupus, right? So she's got a deep knowledge of the ways that lupus might impact someone's ability to move. And so she tailors the program accordingly. Yeah, great question.
I love the fact that the exercise program allows to help diminish the depression and anxiety.
Yeah.
It's like monitor the body's life. The depression and anxiety is it, it kind of assuages it for an hour or two, and it comes back on as it was or have you been able to kind of gauge.
Who set your question up so perfectly for me? We have problems with how we measure. And I think that's the root of the problem that you shared is that, say, I'm going to change all of the information on here, but I want you to focus on the meat of the graph. You come into my lab before I have you do an exercise program and I test, your depression and you're having a quote unquote bad day. And so that's where I say you start and then you do my intervention or time passes, you come back, I give you that same test and you're having a quote unquote good day. Well, now I am thinking that my intervention is the bee's knees and it might not be. And so
what we know is that in chronic conditions, especially lupus, there's variability between days, but also within day. And the ways that we do cross-sectional snapshot studies misses that completely. And what we're doing now, and it's called CogDetect, is one of my other studies, where we're bringing people in to do a one-day assessment in the lab. So getting those typical cross-sectional measures of this snapshot. But we're also encouraging people to come or to wear a accelerometer, which is a research grade Fitbit equivalent, and answer questions on a cell phone that we provide 4 times a day. And that's a measure of testing called ecological momentary assessment. And so it gives a more comprehensive understanding of how your symptoms are changing within day and between day. What we do then is we take the average of that 2-week period and we say, this is your average. And each day we judge, are you above or below your average? So I'm not comparing you to someone else because that really doesn't matter. I'm comparing you to you, and that's what does matter. So to answer your question, do I know if these programs are able to, like, how long the impact is? Not well enough. We are integrating this into how we measure our outcomes for all of our studies. And so I will have a better answer to that. But what we do see is that at that other kind of non-ideal way that we measure is a sustained effect. So 2 months post involvement in our study, we did still see decreased levels of depression from where people started. But that's about as much clarity as we have. Yeah. Awesome. Perfect. I got my red sign and no more questions. Thank you so much. Oh, sorry. I told everyone I would do this. I'm doing a quick plug for Melissa. One of our graduate students is conducting her master's thesis, looking at decision-making, decision-making internal dialogue that you have when you are deciding to exercise, if you have both lupus and cardiovascular disease. So if you have both conditions, we'd love to have you as part of our study. Thank you. Hey, let's just check the Zoom if there's any questions. Nope. We have, yeah. Okay. Next up, we are going to have our lived experience with lupus and caregiving for lupus panel. So that is going to be moderated by Rachel Bergmans. I'll invite the panelists to come up, but I'll pass it over to Rachel. Do you want to come on up? Yeah. Well, thank you so much, all of you, for being here and wanting to share kind of your perspective today. I just want to start with perhaps everyone giving an introduction of your name and why are you willing to be here and kind of share some of your story. Tiffany, go ahead.
My name is Tiffani Stokley. I was diagnosed with SLE in 2006, and I'm here just to empower, share my experience. So I think shared experiences make you feel less alone.
Hello, my name is Javon McCoy. I am a member of Lambda Sigma Sigma Lupus Sorority Incorporated. I was diagnosed in 2021 with lupus nephritis with crescents, which I was told was a severe case of lupus nephritis. And I am here just to share my story and let everyone know that they are not alone. It's other people out here struggling, surviving, and navigating.
My name is Shabazz Ford. I'm here to just speak as a caregiver. My wife was diagnosed with lupus in 2018. So I also want to say all of you are inspiration just to be here and share these stories because I've seen what she's went through and I applaud that.
Good afternoon. My name is Shannon Hester. I was diagnosed with lupus nephritis in January of 2002. And I am here because I want to get my story out and just let people know that there is a community out there with similar experiences.
My name is Leontyne Holmes. I'm Shannon's mother, and I'm also a caregiver. And I'm here today to just answer any questions that anybody might have and just let them know that caregiving isn't an A, B, C, D, E. Everybody's caregiving is a unique situation.
My name is Crystal Ford. I have lupus SLE. I was diagnosed in 2018. And my goal is to just to make people aware and definitely get the word out to physicians and patient clinicians so that they can be more aware of what symptoms to look for, that they may be misdiagnosed. Good afternoon, my name is Lisa Thomas, and I tried since Tiffani started speaking to remember my date, the year diagnosis. Sorry. But I do know that I moved to Washington, and that's when I learned that I had lupus, had experienced symptoms for a while. I am here because I want to encourage and empower people to know to advocate for yourself. That's my goal.
Thank you. So let's just dive right in. I want to start with those of you who have lupus, and maybe we'll start at the other end for this question. So communicating with your doctor and multiple specialists can be an important part of obtaining good care for lupus. What has been your experience with provider communication, and do you have recommendations for creating an effective care team?
Okay, so in the beginning, like I said, there were years of symptoms. They would be hit and miss. And so at that time, I couldn't string anything together. However, the rheumatologist that I did see it the first, it was her words. She said, come back in a year. Well, my symptoms were increasing daily, weekly, and that wasn't enough for me. And that put me in full throttle to go and seek care for myself. So I began to ask around. I asked a rheumatologist. I wanted a rheumatologist that heard me. I was just not a picture or a face. I did experience one PA told me, well, what is your pain level? And I said, it's a 10. And he said, well, I asked my girlfriend the other day, what was her pain level? And she told me it was a 10, but she was laughing. I said, well, mine is a 10. And this hurts worse than 2 boys that I delivered to. And he had a chuckle and I wasn't. So I experienced some of those things. The final rheumatologist that I ended up with, it was important that he understood me, he heard me, knew that I wanted to be a part of my care as much as he wanted to care for me. So that relationship was important to me, and that's what I sought out. You asked what advice would I have? Being diligent in your care. Don't just take no. You know what you feel. You're the best caretaker of yourself. And when I mean that, I mean, you know what your body is going through. You know what that pain feels like. You know what the fatigue feels like. Something's not right. Keep at it. Thank you.
Crystal, do you want to add to that or share some of your experience?
Yes, definitely communicate. Like you said, yeah, advocate for yourself. Don't allow the doctors to just feel like they're afraid to leave or that's over exaggerated. When I first started having symptoms for to go to the hospital, I was told I was going through depression and anxiety. And you have to continue to speak up for yourself and continue to visit and what you feel and what you believe.
Shannon, same question in terms of tips or kind of your experience with navigating a care team.
Just to piggyback off of what Crystal said, you want to find a position where you feel as though your voice is being heard, like your questions and concerns are being addressed. You want to feel like it is a team effort. So you definitely want to be able to have a position that is open and receptive to what you have to say as far as, you know, your treatment and how you feel. So I think that's one of the steps for a good care team, making sure that your voice is being heard.
Javon, please feel free to answer that question, but I'm also going to ask another one for your input. So lupus symptoms and flares can be unpredictable. One day you may feel great and take on more than you should have in hindsight. How do you approach pacing yourself, including when symptoms affect your life plans and daily activities?
In reference to the first question, about going to the doctors and navigating different care teams, you have to aggressively advocate for yourself. Don't be afraid to fire your doctor. This is a job. You didn't go to medical school and they don't know you. So you have to aggressively. And if you feel like they're not getting you or not understanding you, leave. I put my clothes on in the doctor's office so many times, like I'm gone. And they're like, what are you doing? I'm like, you can stay and watch or you can leave, but I'm leaving. And I put my clothes on and I leave and you find someone else. If you have a good doctor that's working with you, have them recommend people to you. Because in that respect, birds of a feather do flock together. So they'll refer you to someone who is similar to them and that will work with you. In reference to my pacing myself, I have a 10-year-old and 11-year-old. They roll, they play volleyball, they box. I don't pace myself, but I pay for it. But you have to have, like the caregivers up here, you have to have a good support team. I know when I've overdone it and I'm like, yep, I'm gonna be out a couple of days because I'm out in the sun at volleyball. I forgot my sun hat at home, or my sunscreen has worn off because we've been out here all day. So I'm still navigating and learning things, and that's a good thing you have to do too, is know your body. Like Dominique said, I know my body, so I know I'm about to be down for a couple of days. But that's when my support team steps up, or I just have to tell my kids, someone else has to take you guys today because mommy can't do it. And they're old enough to where they can understand things. But I'm newly diagnosed, 2021, so I'm still figuring and navigating things out myself.
Tiffani, you want to add about your questions?
Yeah, this is more like because I have other conditions besides lupus, and so I see multiple specialists, and so navigating that is can be a challenge. But I would say the patient portal is your friend. Like, I will copy and paste the same message to 5 different physicians. Like, especially like if I'm admitted to the hospital, I just go, I'm admitted. Or if I need 2 doctors to talk to each other, like, hey, can you, this is what such and such say, can you talk to, I wear that patient portal out. And also not to assume that they're going to talk to each other. Because one day I was a little irritated, but I was like, okay, I was just thinking about like primary care, for example. They have like 1,000 patients each or something crazy like that. So you really have to step up and make sure that all your physicians are communicating, that they'll be on the same page, even because they might not agree on the course of therapy. And then in terms of taking care of myself, I think I'm still a work in progress. I learned, because it's hard to, I've always been someone who, even now, like, I'm independent, I live by myself, I take care of myself. And so sometimes it's hard not to just do things myself. But I'm learning to like I have to step back, I have to redo my budget so I can start paying people to do things for me. Even if I can do it, yeah, I can do it, but then what's the cost? What's the cost of my time? What's the cost of me missing an event because I'm too, not feeling well because I went and tried to lift something that I wasn't supposed to. So I've been trying lately, especially this last year, really figure out my budget so I can start paying people to do things maybe that I would do myself, And then even I go to what was I getting ready to say? See, brain fog. Anyway, yeah, that it is trying to, and I can be very independent and prideful and accepting help and like getting over that ego of, well, even if I could physically do it, sometimes I just still need to get help, you know? So those are some of the things that I'm trying to do to take care of myself, getting more help, working on my ego, you know, getting my budget to where I can start paying for some things to have done. So.
Thank you. So my next question is for the caregivers on the panel. It'd be great to just hear, you know, how has your life changed since becoming a caregiver? And if you have reflections too on kind of supporting someone's journey in the context of the medical care that they need to receive.
Well, you said as far as, repeat the question.
Yeah. How has your life changed since becoming a caregiver?
Well, I want to say that from my experience, it really wasn't overwhelming, first of all, and because of the type of mother that I had. My mother was a nurse. When Shannon was first, all this stuff came about. Her girlfriends brought her home from college. And I will never forget it because that was the weekend at Princess Diana that I was in the PI. And she also had to have rhesus treatment. There was so many things that just didn't know what was happening. I was crying. And my mother took me out of the room, went to the bathroom, and she told me, cry while I was there. Get that cry out, because I had a business that I had to take care of, and that was taking care of her. So my mother kind of taught me, and as far as my life changed, she showed me how to be able to take care of her. But like I said, everything wasn't just, you know, like cut and dry. I had to write things down. My life changed because I had to think more of somebody else. Now, we always do because we have children. You know, we always think, but this was a little bit different. I was younger, but I just never thought that I needed to be doing anything. My life changed because I was more focused on her. But then again, I had two daughters that were extremely sick. At the same time, Shannon's youngest sister had a very rare form of ovarian cancer. At the same time that Shannon was diagnosed with lupus. As a matter of fact, they both were in the and Shannon was in U of M and Meg was in U. And to the fact that they both thought that they were only children. Because, but my life it didn't change for the worse for me though. I never regretted what I had to do. That was just me. But again, it's because of the background, you know, that I had when I talked to other caregivers. See, they didn't have that type of background. They didn't have that type of support. And so a lot of caregivers that I have talked to, they're resentful. You know, this is something that you got to do out of love. And they feel as though they're missing out on something. I never felt like I was missing. So as far as my life and how it's changed, it's a little bit different, you know, because of my background, because of the type of mother, you know, that I had. But she was a no nonsense, and she was like, girl, you got to get up and do what you got to do. So, and that's how I was taught. That's what I did. I feel though my life has been enriched by taking care of Shannon. We become closer. We can talk about anything, you know, and we can disagree about a lot of things as well. So for me, it's caregiving, and it ain't been easy. I'm sitting here smiling, but caregiving is not it's not for the weak. You can attest to that. You know, but I have, I can't see my life any other way. That's all I've known. All I've known is caregiving. You know, my daughters were sick, my mother took care of my mother. That's all I've ever known. So I can't sit here and say things like, oh my God, I wish I would have did this. Because when we have good years, when we up, we up. You know, we do things, but when we down, we down. And I don't say, oh, this, it's just like I said, it's just a little different experience for me. And I have a good support system in my church family. So a real good support system, real good support system, not only in prayer, but some people that I can call and I can do. Yeah. Because you know, everything is about praise the Lord, hallelujah. Sometimes you know that when you know. I have a good support system. So as far as changing my life, this has been my life. I don't know any other way. I really don't.
Thank you. That's really helpful perspective.
And everything that she said was spot on, even with me, because I met Crystal in 1995. We were 15 years old, and I told her, I'm gonna be with you forever, whether you like it or not. Even when she just woke up one day and she couldn't walk, I carried her down the stairs, into the car, into the emergency room. They had no clue of what was going on. They allowed me to carry her out of the emergency room, back into the car, back to the house, back up the stairs. I wasn't satisfied, so I'm calling around and back down the stairs, back into the car until we get some kind of answers. And even when she was admitted, I was there, I was security. They didn't even have to come in and make her bed. I took care of all of that in the hospital. But yeah, that's my life. That's what it is. And it's important for me to also allow my children to see what love is. So
Thank you so much. Lisa, going back to you.
Right.
You know, lupus requires a lot of effort on the individual, coordinating doctor's visits, adhering to treatment plans, using other self-care strategies, identifying those strategies. It can have a major impact on emotional and mental health. What are ways that you promote your mental wellness? And are there any activities or resources or strategies that you can share?
So, I am an advocate, not only for lupus, but mental health awareness. I am currently in therapy. In the Black community, therapy is taboo. So let me tell you, when you are living with a chronic illness, and such as lupus, as we're speaking about, you need that. My dear friend over here for you, who is also a lupus warrior, time and time again, because it took years. I want to say my first symptom was in 1999. And she was just saying, Lisa, maybe somebody to talk to. But I'm like, I'm talking to you is what I'm hearing. But she didn't mean it in harm. It's just the weight of what you're trying to deliver. And even though she was an advocate herself and encouraging me, she spoke those words. And I implore anyone who's living with chronic illnesses, please seek mental counseling. That makes me better. It helps a lot. You know, for someone to sit there and listen to you for 50 minutes and it's anything that you feel, you know, and give you feedback and encouragement and tell you how to take one bite at a time. You know, our phrase that we hear in lupus, and I think someone touched on it down there, is don't overdo it. where's the line in the sand of what overdoing it is? Usually we're pushing ourselves because we want to push through with repercussions later. But for the ones that I love, I don't mind doing that. It comes, like you said, the practicing, we have to take a pause, but please, seek counseling. Tell your family members too, you know, the caregivers. Like she said, she need a drink, which I'm sure. But they need that also. Like she said, just holding the phone, and it's not always praise the Lord, hallelujah. It is, I need to release. It's just so, it's like the gates of heaven opening, you know, to have that and learn something about yourself. And it being mentally healthy helps to navigate with this condition, you know, in front of you.
Crystal, are there resources or things that you do that support your mental health and emotional well-being that you want to share?
I'm a work in progress as well, but I found support myself tremendously. I'm not out and about. But definitely I find that support myself tremendously. Also praying, my family, my husband, he keeps me up, you know, upbeat all the time. He's very comical. Sometimes he plays too much, but but you know, my kids, you know, my mom. I have a very supportive family as well. Uncle, I like him a lot, you know. But you know, definitely praying, just trying to keep my mind going. I try to refrain from watching the news all the time, social media, too much. I also already deal with, you know, some days I wake up worrying, like, what if? My mind's always going. When I look at my kids every day, it's always like, oh, we gotta be here, or what if? So I really try to keep my mind going on the positive note. And I just can't stress enough prayer and family.
Yeah, Shannon, anything you'd like to add to that as well?
I think in addition, for me, it's also doing things that bring me joy, the things that I enjoy also help my mental. So I like horror movies, so I watch horror movies. So, you know, that's that's, you know, that's what I do. So that, you know, that brings me joy. Or I'm a nerd at heart, so I like reading books. So I have books that I buy and then I read. So just doing something that doesn't have to be anything big, but it's just something, you know, that just makes you feel good, or something that that helps you as well.
So I want to switch back to the caregivers again, and just thinking about the supports and things that have been helpful. You've mentioned some things like friends and family have been supportive. What other ways do you find, you know, time for yourself, or what moments do you find yourself needing to check in with yourself to make sure that, you know, you have your oxygen mask on before you can be a caregiver to that person in your life?
Early morning is not morning. I'm a early morning person. So when I get up in the morning, sometimes I'm up at 6. That's my time. That's when I take the breather. You know, I might, if I want to watch a movie or something, I do. That's the time that I do. And sometimes when they got to the point when Shannon just could not, she really needed like 24 hours care. That would be my morning, was my time. I would go outside. You know, I would sit on the porch or something. I would walk, you know, at one point we were at home and got to go outside, walk a couple of houses down, walk a couple of houses back, you know, and go in. But that was when I would kind of carve out time for myself, for my memory, and I would plan my day during the and that I also, one thing I want to say about caregiving, if anybody has children, is like when
have a baby and they say you sleep when the baby sleep, and you be up when the baby up. Sometimes when caregiving gets that rough, and there's so many things, Shannon's been bedridden, before. I would go with flow. Things would change priorities. It was never, this is something I gotta do today. If I thought that was something that I had to do today, something else could come on. So I learned how to kind of roll with the punches. Okay, today was the day with that maybe she had a doctor's appointment, whenever she has doctor's appointments. That would be the day, would be doctor's appointment. You could never, as a caregiver, say, well, okay, after this doctor's appointment, I'm gonna run over here to the grocery store right quick. Or maybe I'm gonna stop in the store and get something like that. No. When we went to the doctor, it was just, that's what was there for that day, because when you have lupus, as you know, when you go to the doctor, it ain't always in and out. It's, well, let's go get this blood over here. Or why you here? Can we do this? Or can you do that over here? Or maybe that's run. Can you wait for this prescription? It's just a lot of other things that could come, come into play. So as a caregiver, again, I switch my priorities. Everything, if something else might come up that's more a priority to what you thought, was going to be. And I would just roll with the punches. Early morning was my morning. I would make myself get up, even though I was tired, to make sure my mental health was together. And then from there, then we would start the day. And again, the day depended on her. It didn't really depend on me. It's like, okay, is she up for that? Doing the medications, we got stories. You seeing us on the upside. This is these past 2 years have been thumbs up. But within all of 2 years, this been some thumbs down, just like the gentleman here was talking about caregiver. Oh, and yeah. The nurses, she always wanted to take care of Shannon because they didn't do nothing. I remember when I was coming and she was telling them to the nurse, just leave the sheets and stuff on the bed. My mom will do it. Oh my God. So that's fine. So I know I digress. I'm sorry. Yeah, you've seen Shannon and I at this day. These past 2 years, these are 2 good years. But before these 2 years, it wasn't. I wouldn't see me with lipstick on.
For me, it was, I believe that mindset determines the outcome of everything. So when Crystal was diagnosed, it was rough. When she came home, I had to learn how to clean a trach, feed her through a stomach tube. I had to learn a lot on hand, but it was never an issue, whatever she needed. But I had to find something to do to relieve myself that my family could also benefit from. So the gym became therapy. And, I looked up a few years later, my wife was doing a little better, but with that being said, I also understand the bar is different. Her good is not my good. So I have to show her grace in that, like if she say I'm good, that means one knee just hurt today or, it's different. But I looked up and she was moving around better. I was 200 pounds lighter. So the gym is therapy.
Gonna go a little off script before we get to our last question, but we talk a lot about how lupus can be invisible, how people may not understand. And Javon, I was just curious about what are some misconceptions you've run into or times where you really faced that in your life?
Being a sexy plus size woman. That's what they always tell you. If you can lose a little weight, you will feel better. If you could just lose 5 pounds, you can do this, you can do it. It wasn't even an exam. It was always, oh, well, you just need to lose weight. That's the only thing it is. Or you're not really in that much pain. So that's why I say you have to aggressively advocate for yourself. I knew something was wrong with me and it had nothing to do with weight. So a little bit to do with weight, but the majority, I knew it wasn't. No matter how much weight I lost, I knew I'm going to still feel this way. So you have to aggressively advocate for yourself. I found a primary care physician, a Black woman who first day worked up from head to toe. It was not about my weight. It wasn't, it was just, what's wrong? Okay, I'm going to run this. You know what? Let's just do the whole thing. And within a matter of a couple of weeks, all this stuff came back. I had an underactive thyroid. I had the protein and the urine in my blood, and she sent me to a kidney specialist. But all of this was COVID had just hit. So those test results came back in October. I wasn't scheduled to see the kidney specialist and nephrologist until March. I collapsed in January. I should have actively, pursued like finding someone else to go to, but just that diagnosis got me on the right start. So you have to aggressively advocate for yourself. And if one person is telling you something and you know in your heart, keep moving. Just keep moving. So I would say that's a good way. It is a silent, and I call it the misery illness because it loves company. I went into the hospital not knowing what was going on. My oxygen levels was at 60. My kidneys were shutting down. I walked out of the hospital with COPD, lupus, high blood pressure. But I'm someone who I always have to find the humor and stuff, because if not, I would be a mess. And I have two little ones, like the mom and the husband say, I have someone else I have to look after no matter what. So I always have to find the positive and stuff. So I'm always upbeat. And like she said, 6 a.m. is her. I'm a soap opera girl. So when my kids are asleep, I'm in the shower, boo-hooing. That's my time. No matter, I don't let my kids see the negative. I'm in that shower crying. When that shower were to go off, it's nothing but sunshine and roses. And that's what they see. Yeah.
Tiffany, same question in terms of how you face some of those misconceptions or.
I wanted to, because the pain thing, it struck a nerve with me. So you go in and they're like, oh, what's your pain level? And I think that should be reconsidered when you're dealing with someone who deals with pain all the time. So a lot of times, something if I go to the ER, like, what's your pain level? I said, so I've had a bone marrow biopsy, and that was painful, So, and then also, just because I don't display that I'm in pain, because usually when I'm going by myself, and my family lives far from me, so they might meet me there. But I have to advocate for myself, so I have to compartmentalize the pain so I can communicate and get the care I need. So sometimes they'll want to look at you, because even one time I actually had an aneurysm on an artery, and it was super painful, but I had to keep my and one of the nurses, and I was cracking jokes because I didn't want to just bust out crying. And she was like, you got to stop laughing because they aren't going to think anything's wrong with you. But I'm like, I think that understanding needs to be there. I can't communicate with you if I'm or rolling around or whatever. And then also breathing and being calm, I feel, and I've learned for me personally, kind of dims the pain a little bit. So I think that's one of the things that I think from an invisible type of thing, you can't see pain. How are you going to see my pain? And just keeping that in mind. And then also, so I was actually fit when I was diagnosed with lupus, which takes me off today, but because I'm not, I'm like, how am I to get back there? And so I got blown off a lot. It actually took me for the first time, because I was working out and I would always feel horrible. I'm like, this is not supposed to happen. And so from the time that I first went to doctor's offices, something's not right. I've been working out, and I even switched because I was running, and so I switched to walking. I was like, well, maybe I just need to tone it down a little bit. But I think I was 22 the first time I ever went and said something's not right. I didn't get diagnosed till I was 32 with lupus, and by then it was obvious. My immune system was killing off my blood cells. I needed it was obvious something was wrong. So I think in terms of like stigma of like right now, it's the stigma of my weight because everybody's like, well, you must have high blood pressure. I'm like, that pharmacist done told you I don't have high blood pressure. Like, you know, like I don't have high blood pressure. I don't have clogged arteries. They looked at all that. Like, yeah, I need to lose weight. I want to lose weight, but that's not what you need to be focused on is high blood pressure because it's not an issue. So it's like kind of making sure that, you know, advocating for yourself to make sure that they're looking at the right thing and not just looking at, oh, well, she's overweight, then it must be this, and that. You know, I'm like, look at my chart, you know, like you'll see like what's going on. So I think that's a lot of the visual, and then the whole pain thing. And then just even being able like to, you don't always express how you are physically feeling.
So I guess I just have one last question for everyone. We'll start at this end, but just kind of, you know, what would you want to share with someone today who just learned that they were diagnosed with lupus or just learned that someone they love was diagnosed with lupus? And maybe it's what you wish you had heard or something that really benefited you along the way.
When I was initially diagnosed, support groups helped a lot. Because I could ask questions, I would get a lot of reassurance. So I think support groups are very helpful. You have to find the right one because there's some radical support groups out there where people are like, it's just weirdness because you're just dealing with people, right? And some people can be weird. So I would say support groups.
I would say do what makes you happy. Try what works for you. Try something, and I'm a believer in if it doesn't work, don't do it no more. Don't feel like, oh, I got to see it through. You saw it through. You went, you tried it, you didn't like it, move on. As far as the support groups, she went, she didn't like the radical one, she moved on. Support groups don't work for me, so I moved on. So you just have to do what is best for you. There's not a textbook way to handle lupus. Everybody is different. So you just do what works for you. Listen to you. I can't stress listening to yourself enough and advocating for yourself enough. No one's going to listen to you. You have to make them listen.
As a caregiver, I would say, in regards to what she said, listen to your loved one. Pay attention to how they feel so that you can gain a better understanding. Because I think sometimes we utilize our outlook on situations and try to judge and gauge how somebody else is feeling. Well, we can't do that. So I had to really pay attention to, like I said before, her good isn't my good. And I had to learn how to operate on that level with her and not take it for what my good is.
Repeat the question. Yeah, what would you tell someone who was recently diagnosed with lupus? Maybe something you would have wanted to hear or something you've learned along the way.
Make sure that you have the right physician or the right doctor that you feel you're aligned with. Going back to what I said earlier, making sure that your voice is heard. And I think go from there because I think that really helps for you to express what's going on and for you to feel like you and your doctor are a team. So if you don't feel that, or you feel like you're being gaslit or whatnot, or they're just telling you things to do and not listening to you about how you're feeling. Like she said, if you don't like, no, on to the next one.
As a caregiver, one of the things that I would suggest to someone who was newly diagnosed or someone who was taking care of somebody that was newly diagnosed is let them be in control. You are there because you are playing big. You're there when they cannot advocate for themselves. That's why you are there. Write things down. We have a medications change. We have it on our computer. We update them because as a caregiver, when your loved one is sick and they cannot advocate for themselves, even though a lot of times the doctors think they know, they'll come to you. You know, what is it? What do you think? And sometimes they're not. You know, I've had to write letters and get with a few of them too. Because one thing as a caregiver, like I tell them, Shannon is an adult. So the first thing they'll say is, well, she's an adult and you can't speak or whatever for her. And I always tell them, if anything goes wrong with her, who are you gonna come see to sign my name on the dotted line? It's gonna be me. So not only do they have to advocate as a caregiver, you have to advocate too as a caregiver. You know, this is my loved one. This is what I have. I can show you. We have books from when she was newly diagnosed. So for caregivers, just communication, listen, let them be in control, but you have to roll with them. They are in control. And the worst thing that can happen between a caregiver and someone is that you take care of, if they feel that they don't have any control of the situation. Now that will turn things and start going downhill. From there, you can't take over as a caregiver. You're there as the complement them. And when you go to the doctor's appointments and with these doctors, when they realize that, now when I've been sitting there, they'll ask Shannon a question and look at me. You know, but my thing is, as long as you see me here with her, then things are going on. That's when we worry. But when you don't see me here with her, everything is going okay. Because I don't feel like, she doesn't feel like I need to be there. I don't feel like I need to be there. But I do keep, we keep on our desktop medications, going back, surgeries, going back from the day that she was diagnosed, because when things go down and when it becomes an emergency situation, the doctors, they don't have time to go back and look through things that happened 20 years ago. You know, we have it in the book. So I'm like, look, and this happened in 2001. This happened 2002. No, you know, she can't do this. And they're writing it down. And then they ask me for my book, but no, you can't have it. You know, because they, well, can I take this? No, you cannot take it. But you can come back and you can ask me. So as a person that's newly a caregiver, I can only speak for the caregiver part, you know, become active, but let them be in control. You're just there as family.
I recommend speaking up. I can't stress that enough, being an advocate for yourself. Ask questions. Don't be afraid to get a second opinion. I had to switch neurologists, and I just found to all my gut feeling. So I can't stress that enough. Don't feel intimidated just because they're a doctor. Doesn't mean that they're smarter than you. You know your body. You know how you feel. If you can have someone be there with you at every appointment, if you're just newly diagnosed, it's really important too, because they give you so much information and then so much to retain. My husband was at every appointment with me for years. And just like you said, if you saw, you need to be there. If you wasn't there, I was there. But I communicate everything to him, every appointment I have. And medication change, you know everything. So if you can have someone with you, even if you feel like you're good, it's always good to let someone know what's going on with you. Advocate for yourself. I can't share it.
I would say a few key things. One is hire a team that hears you and that you're a part of your care. Make sure that you are giving your caregivers or loved ones grace as you would like, because it's hard for them to ingest. And third,
On your okay days, take it easy. On your good days, celebrate them. And on your bad days, rest. Those are all different. And if you're a woman of color, please understand that this walk is harder than those who are not. And be prepared for that journey. It comes with tons of hurdles, but you'll get there. There will be some frustrating moments, but you'll get there.
Are there any questions from the audience or online for our panelists?
Next is just your closing remarks.
Thank you. So I just have a few last comments as we bring this incredible day to a close. I just want to say a huge thank you to everyone for being here. Today has been full of insightful presentations and thought-provoking discussions. To our speakers, thank you for your expertise and for sparking such engaging conversations. And to all attendees, your questions, comments, enthusiasm have truly made this day special. A special thanks to those who shared their personal stories. Your courage and openness bring an essential perspective to understanding lupus. Though our time together was short, let's take what we've learned and keep moving forward towards better resources and treatments and a cure for lupus. Safe travels home, and we look forward to seeing you again soon. Thank you, everyone.